Good evening, everyone. I welcome you all for today's webinar on Onco Talk 1. And with great pleasure, I would like to invite a program convener, Dr. Ashish Upadhyay, who is Consultant Department of Medical Oncology and Hemato-Oncology at Fortis Hospital, Kolkata, for the welcome and introductory note and to take the proceedings forward. Over to you, sir.
So good evening everyone. So I welcome you all in this webinar called Onco Talks 1, where we have decided that every frequently we'll be discussing multiple upcoming topics in oncology. Different experts will be coming and discussing relevant topics. And also we can discuss some complicated cases over here. So we have multiple talks and panel discussion lined up. So without further ado, I would like the team to start the webinar. Thank you.
Yeah, sure. So to start with the webinar, I would like to invite Dr. Sunny Khanna from Kolkata for his talk. Over to you, sir.
Thank you, organizers. Thank you, Ashish. I'll be sharing my screen. Is my screen visible?
Yes, sir.
Okay. So, thank you for the opportunity. And today my talk will be on borderline resectable pancreatic cancer. Sorry, my screen is gone. Just a second. I will again reshare it. Okay. So, today my topic of discussion is borderline resectable pancreatic cancer. What are the relevant evidences for supporting the neoadjuvant therapy? And what are the relevant evidences which are supporting the upfront surgery in these cases? So I'm going to discuss that. I am currently practicing as a consultant surgical oncologist in BP Poddar Hospital, Kolkata. I have done my MBBS, MS and MRCS, and I am a DRNB surgical oncology from Max Hospital, Saket. So without wasting time, I would go into the topic. The slides are not moving. Some issues.
So would you like us to share those?
Just let me see if I can do something.
Sure.
Yeah. So by the end of my talk, I think so I would be able to summarize all the recent randomized trial and the meta-analysis which are available for comparing the neoadjuvant therapy with the upfront surgery. And also we'll be able to understand what are the different guidelines the Indian and the Western guidelines are recommending for the borderline resectable pancreatic cancers. And we will able to decide practical selection of the patients with the help of multidisciplinary team from who to take for the neoadjuvant therapy and what will be our expected outcomes if we go for the upfront surgery or we go after the neoadjuvant therapy, depending upon the what are the R0 resection rates and what are the rate of survival. So defining borderline resectable pancreatic cancer. Historically, all the pancreatic cancers were defined as either resectable or unresectable tumors, but slowly, with the help in advancement of the surgery and the advent of newer neoadjuvant chemotherapies, we were able to define the tumors which are usually looking unresectable, but they are borderline resectable. And that is being defined anatomically on the basis of the venous and the arterial involvement, where the resection may be possible, but the R0 resection is usually uncertain. And there comes the definition of neoadjuvant therapy, because the neoadjuvant therapy was helping in downsizing the tumor, considering the pancreatic cancer to be a systemic disease to begin with. It will help in treating the micrometastatic disease. And we can also select out few patients who are going to progress early so that the very morbid surgery can be avoided. So IAP protocol of 2016 defined the ABC method of borderline resectable pancreatic cancers, where not only the anatomical or the radiological definitions were considered, but also where we were considering the biological definition in form of certain blood test and the imaging findings, and the other conditional or the performance status of the patients were also taken into account. So the anatomical definitions were depending upon the arterial and the venous contact. The biological definitions were dependent on the amount of or uh, the level of CA 19-9 and the PET-CT markers where it would have suggested that there are enlarged lymph node in the localized region, but there is no distant metastasis. Regarding the condition of the patient, whether the patient is suffering from various comorbidities, having poor performance status, who have the high risk of morbidity and mortality due to the surgery. So NCCN guidelines defines the anatomical boundaries of the borderline resectability depending on the arterial contact and depending on the venous contact. So if we see the definition, then the tumor which is in contact with the superior mesenteric artery and it is less than 180 degree of contact, or the solid tumor which is in contact with the common hepatic artery but it has non extended up to the celiac artery or the hepatic artery bifurcations. In case the tumor is located in the tail region, then the tumor should be in contact with the celiac axis, but the contact should be less than 180 degree. For the venous contact, usually if we can resect the vein and we can reconstruct it without any stretch or without any difficulty, then it is called as a borderline resectable pancreatic cancer as per the venous definition. Now, coming to the definition as per the vein, the tumor contact of more than 180 degree or there is an invasion of the superior mesenteric vein portal venous region with causing narrowing or occlusion. And anatomically, we can define that the inferior border of the duodenum. So if we see there are 4 different types of invasion in the superior portal vein and the superior mesenteric axis. If we see the diagram, this is the normal diagram where the superior splenic vein is coming from here, the superior mesenteric vein is coming and it is forming the portal vein. But if we see the diagram B, there is a unilateral narrowing of the vein. If we see the diagram C, there is a bilateral narrowing. And if we see the fourth diagram, there is development of the collaterals. So as per the definition, the A and B, where there's a unilateral narrowing, was described as a resectable tumors, and C and D were described as a borderline resectable tumors. So the evidences which have shown that as per the duodenal boundary, if we want to consider, then if something is reaching beyond the below the level of the duodenum, then that is usually considered as to be an unresectable or unconstructible tumors. So in those scenarios, we usually don't think of reconstructing the vein. But if the tumor involvement is above that, then we can consider of reconstruction after a resection in such a scenario. So the Hayakashi et al., who considered for the 235 patient, they showed that the tumor resection can be challenging if there is an SMV portal vein invasion and if it is exceeding the inferior border of the duodenum. But in group A, group B, group C, these all resections were count possible. As per the arterial contact, historically the arterial invasions were considered to be an unresectable disease. With the advent of newer agents like chemotherapy and the advancement in the surgery, we have been able to find out the different ways of dissecting the artery and also reconstructing it or ligating it without any difficulty. So different procedures which were described in the literature. The first one is the artery first approach, for when we have 6 approaches which have been described depending on the location of the tumor. As because we see that even after a major resection in borderline resectable pancreas, the SMA margin is the most important margin. And if it remains positive, then the disease might progress after the possible resection also. If there's a lot of time we don't see a grossly visible disease and we suspect that we have done an R0 resection, but in the histopathology, we get an R1 resection at the SMA margin. So the artery first approach has been described, and in 2015 the Japanese have described the mesopancreatic concept, where the tissue around the SMA and the artery or the adventitia, they all have to be dissected. So if we see there is an LV1, LV2 and LV3 level of dissection, where LV3 dissection is comprising of the adventitia of the arteries. So if the arterial involvement comes up to the up to 180° also, we can resect the adventitia and we can take out and the whole of the tumor with an R0 resection. And neoadjuvant chemotherapy has helped in this by downsizing the tumor and having help us to achieve an R0 resection in these cases. So what are the techniques of arterial reconstruction? If the adventitia is involved, then we can directly remove the artery and do a direct anastomosis if adequate length is there. We can transpose different arterial graft such as the splenic or the left gastric artery graft. We can also transpose a venous graft or an artificial grafts can be placed, and the aortohepatic bypass after uh, compromising or removing the celiac artery and making a aortohepatic bypass or the Appleby procedures have been described, but these has to be done in a center of excellence only. If we see that the adventitia is uninvolved, then a periadventitial dissection or a mesopancreas dissection, as I described previously, has to be adopted. And there's a triangle between the celiac artery, the SMA, and the portal vein SMV junction, which needs to be dissected very well. This triangle lies here. It's a 3D image. And if we dissect it well, then we can achieve an R0 resection. There is a recent systematic review and a meta-analysis which has shown that with the advent of the neoadjuvant therapy and then arterial resection, that has a potential for achieving an R0 resection and enhanced survival in selected patients. So what are the evidences? The neoadjuvant chemotherapy has shown the resection rate up to 85% when the tumor in contact with the SMA is around 180°. If we can adopt the different procedures, the significant difference between the resection rates have been also observed. The resection rates after chemoradiotherapy has also been shown to be significant, but we will discuss it later. R0 resection rates after the application of neoadjuvant therapy has been high. So, therefore, the borderline resectable tumors defined as tumor contact of SMA or the CMA, celiac artery less than 180° without showing any deformity can be easily reconstructible. Now, as per the biology of the tumor, as we were discussing, the level of CA19-9 around 500 ml units per ml, or the presence of regional lymph nodes as diagnosed by a FNA or the biopsy or the PET-CT scan, can also determine whether it is a resectable or a borderline resectable tumors. And in the literature, it has been shown the patient who have the level more than 500 international unit, the resectability comes down to less than 70%, and the median survival after the pancreatectomy comes down to less than 20 months. So the CA19-9 level has to be considered before taking up any patient for the surgery. The advent of neoadjuvant therapy, if we see that if we give a neoadjuvant chemotherapy and the CA19-9 level is falling to less than 50% of the baseline value, then we see that the median survival or the resectability rate goes up. With the advent of presence of lymph node metastasis, it has also shown some survival advantage, with overall survival best when there is no lymph node involvement, followed by patient with less than 3 lymph node involvement, and for 4 or more lymph node involvement. This is the KM curve of the survival curve, which has shown a significant difference between when the lymph node involvement is 0 to lymph node involvement 1 to 3 and lymph node involvement more than 4. And the condition of the patient or the performance status of the patient, as we have described initially. So these are the definition from the IAP. Next, we come for the management and what are the evidences for borderline resectable pancreatic cancers. Initially, it was upfront surgery followed by adjuvant chemotherapy plus minus radiation therapy. Now, with the newer drugs, we are following the neoadjuvant chemotherapy followed by surgery, and there are little evidences for neoadjuvant chemoradiation therapy followed by surgery. So we'll discuss one by one. But before that, we go for the Indian consensus guidelines for the management of the pancreatic cancer recently published. And what does it say? It says that the evidence supporting the neoadjuvant therapy, although remains limited, with the literature based on meta-analysis, which are comparing the upfront surgery followed by adjuvant versus the neoadjuvant therapy. But overall, what they are recommending that a neoadjuvant strategy is recommended in all patients with borderline resectable pancreas because of the high risk of R1 and R2 resection, and that has also shown some potential survival advantage. The level of evidence being level 2 and grade of recommendation is A. They have also defined the duration of the neoadjuvant therapy which needs to be given, that is between 3 to 6 months, and before proceeding to a surgery. The exact duration, although, can be decided on an individual case-to-case basis. Regarding the drug, the M-folfirinox or the modified folfirinox or Gemnap-paclitaxel, both are acceptable systemic therapy, but in BRCA setting, we have Gemcis available also. Regarding the radiation, they have recommended that moderately hypofractionated radiation therapy or SBRT may be considered on individual case-to-case basis, and surgically eligible patient displaying no disease progression radiologically or the decrease in CA19-9 following neoadjuvant therapy, they should be taken for a surgical exploration. These are the recommendations from the Indian guidelines. What the NCCN suggests that for borderline resectable pancreatic cancer, neoadjuvant systemic therapy is generally preferred, with modified FOLFIRINOX being usually used for the fit patients. And we have an alternative of gemcitabine-based therapy and plus minus chemoradiation therapy. So the different trials, it all begins with the SWOGS 1505 trial where the M-folfirinox and Gem-nab-paclitaxel were compared for resectable and borderline resectable pancreatic cancer. Although the primary endpoint of this trial was not met at 2 years, survival rate of 58%, but this have shown that with the M-folfirinox, there was some degree of improvement in the overall survival. And this trial also suggested one thing, that nearly 1/3 of the patients which were considered resectable by the imaging, when the slides or the scans were reviewed in the higher center, they were found to be unresectable. So they showed that one point, that the resectability of the pancreatic or the borderline pancreatic cancer should be done at the center of excellence and in a multidisciplinary team where the radiologist who is good in assessing the scans of the pancreatic anatomy should assess and give the regarding whether it is a resectable or a borderline resectable tumors. Next, the aspect 5F trial, which was a 4-arm trial, and it suggested or concluded that there is no statistical significant difference in resection rate for an immediate surgery versus a neoadjuvant therapy, but there was a significant survival advantage at 1 year for a neoadjuvant chemotherapy, with 77% survival compared to the upfront surgery. Among the neoadjuvant treatment, the FOLFIRINOX demonstrated the best survival at the 1 year versus the immediate surgery, and compare with the GemCap or the chemoradiation therapy arm. Toxicity was also higher with the FOLFIRINOX, but overall it was manageable. So neoadjuvant therapy should be considered for the patient with borderline resectable pancreas, and modified FOLFIRINOX is the best one. Next is the PREOPANC trial, where they try to assess the
Sir,
advantage of
sir, your
chemoradiation
time
therapy.
is up, sir. Sir, I would like you to request, please complete in 2 minutes, sir.
Okay, so I will go ahead and I will just say what are the criticism of this trial. It was a relatively young patients, and more than half of the patients had resectable tumors. So this has conflicting data, and the role of radiotherapy could not be defined. So Alliance trial also showed that there was no benefit of adding RT to the arm. And if we compare all the trials, the PREOPANC, the Alliance, and the SPAC, we see that we had some advantage with the neoadjuvant therapy, and modified FOLFIRINOX had the most advantage. Addition of radiation did not show a significant advantage. This is a recent meta-analysis of 9 trial, which has also shown similar overall survival advantage with the neoadjuvant therapy without any significant adverse effect. But with the neoadjuvant therapy, it has shown that there were lower rate of resections. And these are the recent meta pool analysis data. The forest analysis plot, which has shown that all the trials are supporting the neoadjuvant therapy compared to the upfront surgery. Role of radiation following resections, because R1 resection is quite possible In certain case-to-case basis, it has shown that addition of RT is helpful. With the addition of concurrent CTRT has shown more advantage, and hypofractionated or SBRT has shown advantage over conventional fractionation. So the practical outcomes is effect of neoadjuvant has been observed. Increase in R0 resection rates have been observed with possible survival advantage and acceptable morbidity. So clinical pathway which is suggested is a multidisciplinary assessment with the radiologist, medical, surgical oncologist, and the radiation oncologist. Patient fit for M-FOLFIRINOX should be taken for that, followed by surgical resection. Less fit patient should go for GEM-NAP-PACLI, and we should consider trials like PRIOPANC-2. We should wait the trial for perioperative M-FOLFIRINOX studies. Limitations of neoadjuvant therapy is heterogeneity in the studies, and many meta-analyses have mixed the borderline resectable with the resectable tumors. And the ongoing future trials of PRIOPANC-2 Alliance A021806 are going to give us certain answers. And studies of different biomarkers and CA19-9 drop is also going to help for assessment of neoadjuvant therapy response. So the take-home message will be the neoadjuvant therapy improves R0 resection, and it should be advocated. M-FOLFIRINOX should be the standard. RT remains debated. Different guidelines favors neoadjuvant therapy, and future directions like biomarker guided and personalized therapy should be adopted. Thank you.
Excellent talk, sir. Only one question. So basically we all know neoadjuvant chemotherapy without chemo radiation is a standard of care for borderline resectable pancreatic tumor. So would you recommend routine ERCP and stenting in all the borderline cases before surgery or before going to neoadjuvant therapy?
So routine ERCP and stenting is not the ideal thing. ERCP stenting is usually done in patients who have features of cholangitis or the excessive symptoms of hyperbilirubinemia, that is, they are having excessive pruritus. In such scenario, only it is an indication for putting a stent. Initially, there was a cutoff of around 20 bilirubin, which was seen in a trial, but that is not being followed unless the patient is having a malnourishment, where you need to improve the nutrition. Patient having cholangitis or excessive symptom of hyperbilirubinemia, you can go ahead with the surgery.
Thank you, sir. Thank you, sir, for the excellent talk once again. So next we have Dr. Meenu Chandra. She's a medical oncologist from AIO Guntur. So I would request Dr. Meenu to please take over the stage, and she will be talking on molecular classification of endometrial carcinoma and its implications. Thank you, Meenu.
Good evening, everyone. I'm Dr. Meenu Chandra. I would like to first share my screen. Yeah, I hope my screen is visible.
Yes, ma'am.
Yes, Meenu.
Good evening, everyone. I'm Dr. Meenu Chandra, a consultant medical oncologist from American Oncology Institute, Guntur. First of all, I would like to thank Dr. Ashish for making me a part of this. Thank you, Ashish. And my talk for today is carcinoma endometrium, molecular classification, and its implications. First, my talk will proceed in this manner: endometrial cancer classification and its timeline. What are the issues with old FIGO staging, that is 2009? And what is the FIGO staging of 2023? And what are the issues with morphologic classification and the need for molecular parameters? And how are these molecular parameters done, or how is the molecular testing done and interpreted in daily practice? And the risk groups of FIGO 2023 staging when molecular markers are integrated, and the treatment of the risk groups. Well, endometrial classification, the paradigm shift. In 1983, we had the Bowman's model, a dualistic model for endometrial tumorigenesis. And as years passed on, and in 2013, the Cancer Genome Atlas has actually coded many tumors for us, and CA endometrium is one of them. And after that, this data was used in the trials like POTEC. And finally, in 2020 and 23, after the extensive research about this, the gynae oncology societies have actually, the FIGO has actually started and has integrated these molecular classification and other morphological parameters of importance into the endometrial cancer classification or the FIGO staging. Next, first of all, let us learn what are the issues with old FIGO staging, which is the 2009 staging. One is the insufficient incorporation of tumor biology or the aggressiveness, and under recognition of lymphovascular space invasion as a risk factor, and the lack of molecular classification integration, and limited stratification of early stages, that is stage 1 and 2. Well, all the above has led to ambiguity in treatment planning and correlation of the stages with the prognosis. First, insufficient incorporation of tumor biology or aggressiveness. Here we are able to see there are around 1100 samples of stage 1 endometrial cancer. They were actually plotted for disease-specific survival. Those endometrial cancers with grade 1 and 2 performed better, whereas with grade 3 fared worse. And those with non-endometrioid and other mixed histologies had very poor disease-specific survival. Using FIGO 2009 alone, you may classify a patient as low stage, that is stage 1, but they may actually carry a risk profile, which is a high risk profile that the system didn't capture. And another important thing was the under recognition of lymphovascular space invasion as a risk factor. This is actually a forest plot of the meta-analysis, which showed the hazards ratio was less for patients with focal LVSI for overall survival. And when patients had substantial LVSI, the hazards was 2.5. Similarly, the hazards with substantial LVSI was high for DFS also when compared with focal LVSI. Next, lack of molecular classification and integration. Integration into the FIGO 2009 staging. This is actually the when patients of similar stage were actually classified depending upon different molecular classifications. They had different relapse rates and overall survival. Patients who had pole mutation fared well. And next came the non-specific molecular profile, and the next were MMR deficient, and the worst performance were P53 abnormality. Comparing outcomes or treatment decisions based on 2009 staging may have misled, or it has overdone or underdone the treatment because the underlying risk may be different than what the stage actually implies. Thus, we needed a change which incorporated both the morphological features which actually played a role and also the molecular features. Morphological features included lymph node metastasis, locoregional spread, myometrial invasion, FIGO high grade, that is grade 3 versus low grade, grade 1 and 2, other aggressive histological subtypes, and lymphovascular space invasion. Coming to the other hand, the molecular factors which were included or which needed the inclusion were pole mutation, MMR status, P53 abnormality, and estrogen receptor status if it was no specific molecular profile. Now coming to the FIGO 2023 staging. Well, FIGO 2009 staging was done 14 years earlier, and now there has been a change, and 2023 staging actually included multiple subsets in stage 1A and 1B, and also in stage 2 there were multiple stage 2A, 2B and 2C, and in stage 1, stage 3A and 3B also there are multiple subclassifications. It also included focal versus substantial NVSI. It also included aggressive histologic subtypes, and because of this, some tumors which was classified as stage 3A in 2009 actually fell into stage 1A in 2023. And this is actually a comparison between old versus new, and there have been many stage migrations both up and down. Now, the need for molecular parameters and how is it done and interpreted in daily practice. Well, we all know that carcinoma endometrium, the staging is a surgical staging. The patient who is resectable undergoes a complete resection or an extensive staging resection, and then those tumors samples which post resection. First, we do a pole sequencing by NGS. If pole is mutated, we call them pole mutant. If the patient's tumor tissue has a pole wild type, we do an IHC for MMR proteins. If the MMR is deficient, we classify as MMR deficient subgroup. If the patient has MMR proficient or by IHC, the retained expression of mismatch repair proteins, then we do an IHC for P53. If the P53 is abnormal, we put them into the P53 abnormal subgroup. And if all the three are negative, then there is a subgroup called no specific molecular profile. The similar has been emphasized in this slide also. First, we do a pole and call it pole mutant. And then we simultaneously do a mismatch repair and P53. If it is MR deficient, we call it MMR deficient. And if it is P53 abnormal or mutated, we call it P53 abnormal. And if all the three are negative, we get a non-specific molecular profile. What happens to this non-specific molecular profile? Next, further testing is required in this non-specific molecular profile. Well, we are able to see here, this is the NSMP. Then we do a immunohistochemistry for estrogen receptor. Now, if the estrogen receptor positivity is greater than 10% versus less than 10%. If the estrogen receptor is negative or that is less than 10%, we call them NSMP, estrogen receptor negative. When the estrogen receptor is greater than 10%, we look at the grade of the tumor. If the tumor has grade 1 or grade 2, which is low grade, versus the high grade or grade 3. Now, those tumors which are low grade and grade 1, grade 2, they're called no specific molecular profile, low grade and estrogen receptor positive. Similarly, this high grade tumors actually have a migration to the worser prognosis variant, which is NSMP high grade, and it is clubbed with the estrogen receptor negative group. Now, with this, we have totally 5 different molecular profiles of the tumors. Now, how do we get the risk groups of FIGO 2023 when these molecular markers are incorporated into the FIGO staging? Well, this is the 2023 FIGO staging where we have 1A classified into A1, A2, A3, 1B, 1C. For high-grade histologies, just limited to polypore endometrium. In 2, we have 2A, B, C. And in 3, we have 3A, B, A into A1, A2, B into B1, B2, C, C1, C2, and further divided depending upon the micrometastasis or macrometastasis. Now, when this FIGO 2023 staging is clubbed with the 5 different molecular profiles which we have studied above, we actually get the risk groups. That is, to emphasize, FIGO 2023 staging, when combined with the molecular subgroups, with the 5 molecular subgroups we have learned, that constitutes the risk groups. Now, as we all know, risk groups are obtained by 2023 staging plus molecular classification, and there are 4 subgroups: 1, the low risk; 2, intermediate risk; 3, high intermediate risk; and 4, the high risk. How are they actually classified accordingly? We have seen the 5-year overall risk of recurrence in these subgroups, and if the risk is less than 8%, the risk group is low, and 8 to 15 it is intermediate, and 15 to 25 it is high intermediate, and greater than 25 it is high risk. Now, how does the treatment change, or what is the treatment of these risk groups? Well, in a very simpler stance, I would like to say low risk, no adjuvant therapy is recommended. In intermediate risk, adjuvant brachy is the treatment. In high intermediate risk, pelvic EBRT is opted. And in high risk, chemotherapy along with radiation therapy can be given. Well, in a deeper perspective, let us see here. In this diagram, we are able to see a patch of greens. These are actually stage 1, stage 2, and pole mutants. All these are low risk. Stage 1 1A1, 1A2, 1A3, and MMR deficient, along with 1C MMR deficient, are also low risk. And if it has no specific molecular profile and low grade estrogen receptor positive, they also first 1A1, 2, and 3 also come under low risk category. What is the treatment for low risk? For patients with low risk, no adjuvant therapy is recommended. But this actually has to be taken with a pinch of salt, because the survivals and relapse free data we have in the molecular polymutant molecular subtype has been extracted from the POTEC trials, in which both the arms were, some sort of treatment was given in both the arms in POTEC trials. So, was any adjuvant therapy needed for these women? That should actually be given a thought, and we need further data where their excellent outcomes, the result of increased sensitivity of pole mutant endometrial cancers to treatment, this has to be answered yet. Well, coming to the adjuvant therapy of pole mutant, but stage 3 and stage 4A. Actually, pole mutation, as we all know, confers better prognosis compared to their peers. But in stage 3 pole mutant and 4A, due to limited number of patients in the trials, no firm treatment recommendation can be given. However, by a case-to-case basis, de-escalation from high-risk treatment can be considered. This gray line is actually a gray area. Next, coming to adjuvant therapy, there is another gray area, which is stage 1A NSMP high-grade estrogen negative or P53 abnormality, and NSMP high-grade estrogen negative 1A1 and 1C1. We still have a gray area. Here, actually, adjuvant therapy is not recommended, but they actually have a higher risk of recurrence compared to the other low-risk subtypes. And there are also NCTB analysis suggests benefits systemic therapy, however, good results without adjuvant therapy. Coming to the intermediate risk, stage 1B with MMR deficient, NSMP low grade ER positive, 2A NSMP low grade ER positive, 2C MMR deficient with myometrial invasion less than 50% or greater than 50%. All these fall into intermediate risk category. The adjuvant therapy for intermediate risk category being adjuvant vaginal brachytherapy. And a point to note is no adjuvant therapy is recommended, especially for patients under 60 years of age or low grade. Next, coming to the high intermediate subgroup, we have 2A MMR deficient, 2B MMR deficient and NSMP low grade and estrogen positive, ER positive, 2C with MMR deficient with cervical stromal invasion, no focal LVSI and substantial LVSI. All these fall into high intermediate risk. The high intermediate risk patients, adjuvant EBRT is recommended for optimal pelvic control. Vaginal brachy is an alternative option, especially for those patients who underwent lymph node staging and are N0. No adjuvant therapy can be considered, especially for patients who underwent lymph node staging and are pathologically N0 without substantial LVSI or low-grade disease. Well, coming to the high risk, one simple point is any patient with P53 abnormality is high risk, except for a very milder subset here. And NSMP high grade and low ER is also high risk. And stage 3, stage 4, any patient without pole mutation is as such high risk. Well, coming to the treatment of high risk patients, for patients with high risk, EBRT with concurrent and adjuvant chemotherapy, or alternatively, sequential chemotherapy and radiotherapy are recommended. Chemo with or without brachytherapy is an alternative option. For patients with FIGO 2023, stage 3 and 4, which are MMR deficient endometrial cancers, adjuvant therapy combined with immunotherapy should be considered. Well, as we've discussed, the treatment for high risk is both chemo plus radiotherapy. And for patients who have MMR deficient, they can also be treated with immunotherapy. In accordance with this trial, which is Keynote B231, there is an MMR deficient subgroup, which had a very good disease-free survival when pembrolizumab was added to chemotherapy with a hazard ratio of 0.31%. And finally, the take home message of this talk is endometrial cancer, if the patient has low risk, no adjuvant therapy, intermediate risk, vaginal brachy, high intermediate risk, EBRT or vaginal brachy, depending upon the completeness of resection and nodal staging. If it is high risk, chemoradiotherapy plus chemotherapy. And if the patient has MMR deficiency, then pembrolizumab can be added with chemotherapy. Thank you very much.
Excellent talk, Dr. Minu, as always. So, do you think this molecular classification can also escalate or de-escalate surgery in C endometrium as well?
Yeah, actually, the extent of surgery, especially in stage 3 and high risk molecular profiles, they actually recommend an omentectomy also. In those with a low molecular profile, I mean, low risk molecular profiles, lymphadenectomy would suffice. But those with high risk molecular profiles, an omentectomy, and yes, there are differences in which surgery should be performed in a low risk profile versus a high risk profile, yes.
So, Dr. Nimesh is asking, have you started this in your practice?
Yeah, recently, I should say in the last 3 months, I've seen 3 patients in whom I've implemented this. And very interesting to say, I have a patient who is a 65-year-old female. She has come out to be stage 1A, and there were no risk factors. Then I have got a molecular profiling done in this patient, and unfortunately, she turned out to be P53 mutant. Now I will have to put her in. She was 1B, or I don't exactly remember the stage, but as per the FIGO 2009 classification and high risk feature, she was falling under surveillance versus vaginal brachy. But now she underwent an EBRT with concurrent chemotherapy, and now she is proceeding to her adjuvant chemotherapy. So I think, yes, we all should try and incorporate this. As we all know, previously we used to see some patients of endometrial cancer who used to do very well in the same stage, and some patients who used to actually recur within 4 to 6 months of our previous treatment. So now I think such kind of distinction would not be seen, and when we follow this molecular profiling, I guess all the patients will have a uniform prognosis, and I wish to see that.
Okay. Thank you. Thank you once again, Dr. Minu. Over to you, team.
Thank you so much for this insightful talk, ma'am. Now, I would like to invite Dr. Kripa Bajaj for the next session. She's a consultant
Uh,
medical oncologist at KIMS Hospital, Hyderabad. Welcome, ma'am.
so first of all, I would like to thank Ashish sir as well as the entire team for this opportunity to talk on a very important session. Can someone share slides?
Prior to start, I would thank Dr. Ashish Upadhyay, my dear friend, for giving this opportunity in AstraZeneca. I'll be sharing my slides. So, is it okay?
Please open my presentation and make it a slideshow, ma'am.
Yeah, is it visible?
Yes, Dr. Niyanti, it's visible.
Okay. Thank you, Dr. Ashish. Thank you for such academic fiesta which you're conducting. Not wasting much time, I shall start with the topic which has been allotted for me. So today I'll be discussing what are the changing treatment landscape in a stage 3 unresectable non-small cell cancer. This will be mainly like a medical oncologist perspective. So my overview is just a brief definition of what is unresectable and what is the current standard of care and how consolidation has been.
Ma'am, sorry to interrupt. Please share, ma'am, reshare your presentation.
It's not visible.
Yes, ma'am, not visible.
Okay, 1 second.
Ma'am, please open presentation. Minimize it. Make it a slideshow mode.
Yeah,
Yes,
is it
now
visible
visible,
now?
ma'am.
Okay, fine. Okay, so I'll be going into the topic which is given is the changing treatment paradigms, especially in an oncologist perspective, and that in a medical oncologist perspective. So my overview of the presentation would be a brief discussion of what is the definition of unresectable, what is the standard of care, and what has the role of consolidation has done, as it improved or it has become detrimental. So basically a bit data on the Pacific trial using Durva in the consolidation therapy. If a patient is EGFR positive, so what do you want to give in those settings? And finally, the conclusion. So this is just a brief. This is based on the 8th edition of the AJCC. So we all know that we do classify lung cancers as resectable, borderline resectable, and unresectable. So today we shall be focusing mainly on the unresectable group. Okay, that which starts from anything which is N2 or a bulky disease and a T4 subset. So this is the one, but now the guidelines have changed also based on the 9th edition, which I won't be getting in detail of it. If you look into this one, OS by pathological stage, definitely at this current juncture of a clinical practice, we have improved the OS. The median OS has become almost like 40 months when you compare to a 5-year also. And that too, even in stage 3, we are trying to increase. There is a cliche, especially in stage 3C tumors, because most of them, even though we do treat them with the standard of care consolidate, somehow most of the patients, nearly a lot, maybe more than 1/3 of the patients, or maybe even 2/3 of the patient end up into a stage 4 or a palliative setting, which needs to be taken into consideration. So just a brief, what is the current standard? Definitely it's the chemoradiation in this setting when it's not resectable. Sequential, we prefer mainly if the patient's PS isn't good. And sometimes, especially for bulky nodes, we do go with induction, whom we plan that they might be borderline resectable. Otherwise, in unresectable settings, still the standard of care is the concurrent chemoradiotherapy followed by consolidation therapy. So this is the NCCN guidelines. Even the category 1 recommendation is definitive CCRT, especially from 3B onwards. So coming to the main focus of what is the improvement which has happened in consolidation. Why is consolidation important? As we've already seen that the stage 3 divided in A, B, C and substrata has a different median OS. So the ultimate goal is to increase the median OS and also to delay the recurrences. So based on this, there is a huge data which started with a consolidation docetaxel, then came the combination of doci-cis, and sometimes even in case of an adenocarcinoma, we go with PEM maintenance. So these were the multiple trials started from the HOG trial to the SWOG trial. What did they show is definitely there is some benefit seen, but the significance, what the question. So with this, we started with various consolidation trials, apparently didn't show any benefit initially. So currently the Pacific became the gold standard, where showed that durvalumab maintenance, especially in a stage 3 unresectable setting. This trial included patients more than 18 years with a very good PS and who had a greater life expectancy of more than 12 weeks. This needs to be taken into consideration. So the consolidation part of Durva was started within 1 to 42 days of post-chemo radiation, and it was randomized into 2:1 randomization where Durva was compared with a placebo arm. The primary endpoint being the progression-free survival and the OS, and the secondary endpoints where the duration of response, the safety, and the overall response rate was taken into consideration. So if you look into the outcomes, definitely the probability of OS, this Kaplan-Meier graph tells us that maybe if you compare from the beginning till the end, now we even have a 5-year update of the Pacific trial, that's almost 16 months, which says that there is a median OS benefit of 47 months versus 29 months, which is quite significant. And one more important thing to notice into this is even the tail ends, even at 72 months or let it be 75 months, they are quite well separated. But yeah, irrespective of the number, it's kept decreasing. But definitely at 60-month, 134 patients were still alive in the Durva arm compared to that of 56 patients. So this formed a basic standard of care in the current practice. So a overall survival of almost 42.9% at 5 years, which is very significant, especially in an oncological curative setting. So again, if you look into the forest plot, most of the subsets did fare better. Let it be irrespective of the gender. Age, again, less than 65 years did fare better compared to more than 65, irrespective of the smoking status. And one controversial thing of this is the stage 3A did fare better than 3B. So this may be because of the number or what exactly the reason we need to still identify. Rest most of this thing, let it be. Obviously, adeno did fare better when compared to squamous. And here, if you note into this section where the EGFR is positive, those patients, the number is still less, maybe just 29, but still the forest plot has crossed the unity. So this is one subset whenever there is a targetable mutation. So do you want to still use Durva in those cases would be questionable. And irrespective upfront when the Pacific came up, the even now it is indicated irrespective of PDL1 status, but definitely those with more than 25% expression did fare better. So again, looking into the progression-free survival at 60 months, definitely the Durva arm did fare better with a median OS of 16.9 months versus 5.6 months. So definitely if you look into the hazard ratio, which is 0.55, which is very significant. I think this is one important thing needs to be kept into account. And we all know that, especially in a curative setting, if you're trying to increase both the median PFS and the OS, the time of progression, the quality of life, all these things becomes better. So definitely Pacific has become the standard of care and one of the things which we all implement in day-to-day practice. So again, even for PFS, definitely if you look into the all the subsets, definitely all the subsets have done fair well. I'll be talking about the EGFR subset later because we are still going to talk about the LAURA trial also. Or else most of the subsets have done quite better. So definitely, again, if there is an EGFR subgroup present, almost 23 patients were positive. So this is the one subset. We don't have the ALK patients in this group. So this is one subset, squamous histology. These are the two things which I would like to keep in account. And maybe age is one of the factor. Again, if PS is quite good, age is still can taken as a consideration. This is important subset because these were the subset of patients didn't fare better by giving durvalumab. So whenever there is an actionable target, so I think it's better to avoid the immunotherapy upfront. So in those patients, especially if they've had an EGFR positive, so what do you want to do? So in those settings, definitely we have a strong data from the LAURA trial. Again, this showed that the patients who were EGFR positive post chemoradiation, if you put them on osimertinib, and if you look into the Kaplan-Meier graph, maybe initially there was not much significant. That was for just 3 months duration. But gradually at 24 months, definitely the benefit is 65% versus 13% with a hazard ratio of 0.16. And maybe currently we still do have a fair separation of the tail. So this indicates that with significant p-value, especially in a patient stage 3 EGFR positive, I think I would definitely implement this in my practice by giving osimertinib based on the affordability of patient. So again, if you look into the median PFS, definitely even that has shown a benefit versus 38 months versus the placebo is not reached. So again, the hazard ratio is quite significant. See, most important thing in these two subset is the hazard ratio, which was 0.19. And I think this is a quite significant one. And 24 months, or let it be even at 44 months, 45 months, there is a very well separation of the curve. So what is the looking at the forest plot analysis? So most of the subsets definitely have done fair better. Again, the question comes in the Asian population. I do agree that almost 98 patients were included, but still the significance has crossed it. So this becomes a bit questionable in our clinical practice. But definitely, currently, if a patient is EGFR positive, I think I would still implement this into my current practice. And irrespective of the stage, let it be 3A, 3B, or 3C, they have fared quite well. Again, looking into the mutation status, I think exon 19, we all know that osimertinib, the way it acts on target and off target, mechanism of resistance also, it's quite important. And other thing is Chinese and the non-Chinese cohort. I think most of the subsets have done better. And more importantly is again the response to prior therapy. This also has to be taken into consideration. So again, whenever we give osimertinib, as we all know the mechanism, because it's a high brain penetration. So this also reduce the risk of CNS progression. So the risk of CNS disease, which hampers the quality of life. So this has also dealt and shown that or even the death with osimertinib has reduced with an hazard ratio of 0.17. I think this is very significant, especially in a curative setting. As a medical oncologist, I would totally look into the total CNS PFS events, which is comparing like the 29 versus 30, and even based on the RECIST criteria progression also, and even death. So I think this seems quite significant. Yeah, maybe so there's advantage by giving osimertinib, they're delaying the CNS metastasis in these patients. Again, you're reducing the risk. And if you look into the Kaplan-Meier graph, which says that definitely at 24 months, there's almost 83 versus 43% benefit, almost half there is increase. So I think this is one most important factor to be kept in notice, which becomes like almost 41% in placebo arm experience CNS, whereas only 20% in osimertinib. So there is a form that osimertinib can also become a protective CNS mechanism factor. So I think with this, we understand that definitely once a patient develops brain mets, we all know the outcomes are quite bad. So this delay in event also increases the outcomes, the median OS, and also the quality of life to be taken into consideration. So again, if you look into the cumulative incidence of event, definitely with osimertinib, the CNS progression is reduced compared with the placebo. And even the death by any cause needs to be considered. So the cumulative incidence rate of CNS progression at 12 months was 9% in osimertinib, whereas in absence of osimertinib, it was 36%. So this is quite a significant number if we take into a curative setting. So again, the time to progression with osimertinib, all these mattered, and this also delayed in the various metastatic events or the disease progression. So we did have a stable disease response. So these patients are alive, even and free of distant metastasis at the last follow-up, which was almost at 54 to 57 months. So this is an important event which needs to be considered. The time to distant metastasis or death, especially in these patients, has delayed because of the usage of osimertinib in the adjuvant setting after CCRT in a consolidative arm therapy. So the main question comes again, any major toxicities per se? If you look into grade 3 toxicity, the number is there. Definitely there was 35 patients versus 12 in the placebo. I don't know the reason for the grade 3 toxicity in placebo. Maybe it was because of post CCRT, and definitely leading to discontinuation. The osimertinib was almost 18%. And any death related to it is not accountable. We all know in practice that osimertinib main thing is you look into the QT prolongations, you look into the liver functions. And I think that's what is most important, which we look in. Or else, per se in clinical practice, the death because of osimertinib, I think I haven't seen anyway. So which indicates that the toxicity is quite manageable. So what are the other, moreover, especially in these patients, as we all are aware that these patients have been subjected to chemoradiation. So the question comes that has osimertinib increased the toxicity of radiation or chemotherapy which was given upfront? See, most importantly is ILD. Yes, it was reported in 11 that almost 8% in patients with osimertinib arm. So these precautions need to be taken into consideration. So whenever patient is on osimertinib, most of the time these patients have cough and dyspnea. So a regular checkup or a regular HRCT monitoring is very important, because once patients develop ILD, again, the outcomes become a bit bad. Or else grade 3 toxicities are not that many to account. Mainly radiation pneumonitis, again, it depends upon the type of radiation used, the field, and the various techniques. It again depends upon the location of the tumor also, or any pre-existing comorbidities that the patient have. So all these factors need to be considered into account. And moreover, like most of the patients, because of the previous COVID exposure also, there is increased incidence of ILD. So whenever osimertinib has been given in an adjuvant setting, in these scenarios, so the a bit of caution should be taken into account. Rest all, I think it's quite manageable. So grade 3 toxicities, there are few, but the number is quite less. And maybe with a proper precautionary measure, I think the care can be taken in. So now the current guidelines, what NCCN stages, especially a stage 3, we are only talking about the unresectable part. We have not gone into the resectable section at all. Unresectable, let it be stage 3A, 3B or 3C. The current standard is definitive chemoradiation. The most of the patients, we have to give the standard of care, that's chemoradiation, irrespective of the outcomes. But if the performance status is poor, or you can plan a sequential or an induction accordingly to the based on the patient's performance status. But that's not the standard. Only it's more like a precision type, or maybe patient specific factors can be considered. Later, after that, post CCRT consolidation, definitely, as we have seen that Pacific trial and also the LAURA trial, which have shown that there is a significant median OS and the median PFS benefit. So if the patient has any targetable mutation, we have to go upfront with the respective targets available. In case of an EGFR positive mutation, I think currently osimertinib is approved. There are various substrates for ALK, like we have ELINA trial where alectinib has been trialed and tested. So let's wait for that data too. So maybe currently, yes, immunotherapy or a targetable is advised. Even the ASCO has updated, shows that post CCRT within 42 days of completion, patient has no toxicities, or if patient has developed, again the question comes, if patient has developed radiation pneumonitis, when do you want to give IO or osimertinib? It's better you wait for at least 6 weeks. That is what most of the guidelines do recommend. Get a repeat imaging, look for the disease status, look for the toxicities. If any ILDs are present, then that has to be addressed prior to the starting of any of these therapies, because there's a chances of increase in the toxicities post adding either the immunotherapy or osimertinib in the substrate. Even currently, the ESMO guidelines, including the current ESMOs, which happened recently in ESMO Congress also, consolidation is quite mandatory. So I think as an oncologist, we all need to understand that during the treatment, and even the way we increase the survival matters a lot, because main aim is we're going to have an improved median OS, median PFS, a good control of the disease, and moreover, especially this substrate where it's a stage 3, they can progress rapidly into a metastatic or a palliative setting. So by reducing the incidence of events, I think a better quality of care can be given to all our patients. Currently, Pacific trial does say that PDL1 expression is mandatory, but irrespective of PDL1 status, approval was given for durvalumab. So this is the summary of today's presentation. So how to go about? We all know that the current scenario, almost 30% is stage 3. And moreover, 30% of stage 3, how many are curable? We are aware that median OS has improved to 40 months. But again, if a proper consolidation is not given, they end up progressing rapidly to stage 4. And sometimes when the PS becomes so bad, then, it becomes like you're ending up giving a best supportive care. So advantages is you give a chemoradiation, median OS of 17 to 28 month benefit is given. Pacific is again demonstrated almost 16 months benefit versus just a 5 months with a hazard ratio of 0.72. Especially in EGFR substrates, they definitely do better than anything, which shows that a PFS has increased to 39 months. So currently, durvalumab is recommended for PDL1 positive tumors, and EGFR positive patients would get the consolidation therapy by osimertinib. Maybe let the data of the ELINA trial pop up. I think then we'll be more precise regarding the ALK positive tumors also. So with this, I would like to conclude my talk. And again, I would like to thank Dr. Ashish for giving me this opportunity, and also Novartis. Thank you.
Excellent talk, Dr. Nihanti. So we all know Pacific trial is the standard of care now. So especially talking about LAURA trial, I have two questions. First, what's your take on those patients who achieve complete response? Because there are only 7 patients who achieved complete response. Second, do you think the integration of ctDNA can decrease the duration of osimertinib from till progression to maybe 2 to 3 years?
See, I think both the questions are very valid, and they're very nicely put by you. So for your first question, I think even if patient has a complete response, my indication of choice of why I'm going to use osimertinib is I would reduce the risk of disease progression, especially in CNS metastasis. The number is quite less, but I think I would still use in these patients based on the patient's affordability. And the second thing is, yeah, I think in this setting, I would want to use a ctDNA. I think if a patient has a complete response, I think I would prefer doing a ctDNA. And if ctDNA is positive, maybe then I would go for a osimertinib in my consolidation. If ctDNA turns out to be negative, I think I can avoid the substrate also. So I think ctDNA is definitely, like colon currently, it has been recognized. I think in lung also, I'm quite comfortable doing it. And based on that, I can monitor my therapy per se.
Thank you.
Thank you.
So over to you, team.
Thank you so much, ma'am. Next, I would like to invite Dr. Animesh Agrawal. He's a consultant medical oncologist at Apollo Medics Super Speciality Hospital, Lucknow. Welcome, sir.
Good evening, everyone. Am I audible?
Yes, yes, very much. Good evening,
Yes, sir.
Dr. Lewis.
Right. So just give me a moment as I share my slides. Right. So, good evening, everyone. I assume my slides are visible now. Thank you, organizers. Thank you, Dr. Ashish, for the opportunity to talk about a question that, quite honestly, I've been racking my head over ever since we got the Nivo post-op data presented at ASCO this year. So the last 3 months, give or take. And that and then essentially I thought that maybe if I make a presentation out of it, I get some closure, but I doubt I got it. And I hope to put some of that doubt in your heads. So moving on with the topic that I am discussing, which is essentially keynote 689 versus Nivo post-op approach, the use of immunotherapy in the perioperative setting for resectable head and neck cancers. Of course, a bit of background is always warranted, and which starts from the use of immunotherapy in the radiation setting, right? So the preclinical data suggested that radiation therapy can enhance immune tumor microenvironments by upregulating tumor-associated antigen presentation, because of course we are using radiation, we are often using radiosensitizing agents. So maybe there is more DNA damage going on, and then disordered DNA repair, and therefore upregulation of antigen presentation. And then so on and so forth. The hypothesis essentially would be that because of this enhanced tumor upregulation of antigens, we can get perhaps a better response if we add immunotherapy for these patients. But okay, I'm sorry. Yeah. So that was the hypothesis with which several trials ran across the mid 20 teens. Some of them using avelumab, some using pembrolizumab, durvalumab, and even atezolizumab. Most of them randomized, some of them phase through a couple, most of them phase two, a couple of them phase three as well. The immunotherapy in these trials would be just, I'm sorry, just a moment. So, mhm. Yeah. So the immunotherapy in these trials could be used either in the induction, concurrent, or maintenance setting. So for example, in the Javelin trial, we had all three. In the Gortic Reach, again, using avelumab, there was no induction, but only a concurrent and maintenance. The Pembrorad, which is a small phase two study, so was the energy. So Pembrorad used concurrent only, while the NRG used an induction plus concurrent strategy. The Keynote, probably the largest phase three study we do have for these patients in this setting, used an induction, where the induction was just a single dose followed by concurrent and maintenance setting. And atezolizumab was an adjuvant or maintenance only strategy. Uh, Long story short, none of these trials was successful in demonstrating success in terms of either the progression-free or event-free survival or disease-free survival, let alone overall survival. The only trial that came even close to getting something good out of it was the Keynote 412, and even that marginally failed. So the hazard was a good-looking 0.83, but not so good-looking, I suppose. But the 95% CI crossed unity to 1.03, and of course, which is what leads us to the next question. So if for unresectable disease we are not going to do much much for our patients, can we then actually do well for resectable disease? So here the question now becomes reversed. I mean, maybe we think that patients who are undergoing radiotherapy actually have some sort of suppression of immune reaction, immune reactivity, and maybe that is why the immunotherapy isn't being able to do very much about it. Maybe for resectable disease, where the disease is already there in situ, and that is where we are able to deliver some benefit. And if we are going to deliver that benefit, is it going to be only through radiotherapy and chemotherapy, or do we add immunotherapy for these patients? And if we do add immunotherapy, when do we give it? I mean, do we give it in the induction setting? Do we give it in the concurrent or in the maintenance? Or how on earth do we combine it? Which brings me neatly on to the first study for the night, the contender, the Keynote 689, which was, of course, first announced by the manufacturers October last year, presented in April, and we also have the first manuscript presented again, published in the NEJM. Fairly straightforward trial design. Patients with resectable, locally advanced head and neck cancers. These could be P16 positive or negative. These could be of any stage, that is 3 or 4. The primary site could be larynx, hypopharynx, or oral cavity, and the PDL1 TPS was also a stratification criterion. The control arm, surgery followed by adjuvant therapy, which could be radiation with or without chemotherapy as per standard criteria. In the experimental arm, patients received 2 doses of pembrolizumab followed by surgery. So the 2 doses of pembrolizumab were the neoadjuvant phase. After the surgery, patients received adjuvant therapy as dictated by the post-op histopathology. So this is radiation with or without chemotherapy, and this is where the concurrent pembrolizumab would begin. After 3 doses during radiotherapy, the patient would go on to receive a further 12 doses to complete 17 doses of pembrolizumab. So this, in brief, is the trial design. Primary endpoint was EFS. Statistical testing was hierarchical. So PDL1 CPS more than 10. If the EFS endpoint was met, then the power was distributed to PDL1 CPS more than 1. And again, if met, then further to all comers. Another point was that okay, we'll come to that in a bit. So this was the keynote 689. But of course, resectable disease, but not resected. So patients prior to resection were randomized. When we move on to neo post-op, the basic difference becomes clear. Patients were randomized after having been resected. So patients had to have undergone complete macroscopic resection for locally advanced disease, pathological stage 3 and or 4 disease, and around 680 patients were randomized to receive either standard of care, which is radiation plus cisplatin. So all patients were mandated to receive cisplatin with the indication for concurrent chemotherapy could be either ENE or margin positivity, or in this particular trial, multiple node positivity was also allowed as per some of the retrospective data that has now widely become available. So from Boomstag et al., from the NCDV data analysis. So that is the data that we are discussing today. The primary endpoint for this study was DFS. PDL1 was not one of the stratification criteria. So as for the included some patients that were included in these studies, so smoking status, I'm putting that high up here because we tend to find that in most subsites, it is the never smokers that do not seem to derive as much benefit while the smokers do. So for what it's worth, similar number, 16 versus 20% in both trials were smokers. Never smokers, and the remainder were, of course, either current or former smokers. As expected, predominantly male patients. As expected, predominantly oral cavity, so around 60 versus 58%, with a slightly higher oropharyngeal disease in Nevo post-op and a slightly higher laryngeal disease in keynote 689. PDL1 CPS, one of the things about keynote 689 was that the way this trial was designed, around 96% of the patients had to be PDL1 positive, that is more than 1, for them to have the appropriate power to achieve the statistical design, to reach the statistical power that they were testing for. And so only 4% of these patients actually had PDL1 negative tumors. While in Nevo post-op, it is more along the lines of what we tend to see in clinical practice, which is in clinical practice, we should expect between 15 to 20% of patients should have PDL1 negative tumors, while in keynote 689, there were only 4%. So that may be one of the differences. But of course, how that affects everything else remains to be seen. This is the data for PDL and CPS, more than 10, more than 20, and more than 50, as has been reported. So we can see that around 45, so around 88% of patients PDL1 positive in Nevo post-op. So some things that I thought were interesting. Of course, in 689, we do not have the granularity that we have with some of the lung cancer data, and indeed even in the keynote 048. So we do not know what's going on with the patients with CPS 1 to 9, or maybe 1 to 49, or maybe 10 to 49. So when we go into the depths, we always like more granularity, right? And less than 5% of patients have CPS less than 1. That is not really representative of clinical practice. And I suppose for this is not data that we should be extrapolating for these patients. Similarly, for Nevo post-op, I have a couple of questions. I mean, in that trial, the number of patients with positive margins is 31%. I mean, I really, I mean, I just, for lack of time, I will not be asking everybody of like what is your experience personally. But I also went back and looked at the RTOG and the URTC data. I mean, back 20 years back, right? And even there, 25% of patients have positive margins after resection. I mean, I don't know about you guys, but at least in my practice, that number does not hold up. I mean, barely 5% of patients that I get, at least from my surgical oncologist or head and neck surgical oncologist colleagues, I do not get more than 5 or 10% of positive margins. So that I do not know how to explain. I mean, I'm sure they are all competent surgeons. And the second thing, I mean, there were around 23 patients in Nevo post-op with pathological stage 1 and 2. Why would they receive CTRT? Albeit that's a small number on a base of 680 patients. So perhaps we should let it slide, but still, I find it a bit weird. So I just put it out there. A couple of things that I found worth discussing even in the for consort statement. So so for the 689, of course, we do not have the consort diagram for the Nevo post-op. So we'll discuss about the 689 for momentarily. And a couple of things that I found worth mentioning straight away. So around 35 patients on the control arm. So patients who were randomized to go on to be operated straight away. Of these patients, 35 were not treated. What on earth does that mean? I do not know. I mean, patients with resectable head and neck cancer, they get enrolled onto a clinical trial that they want to get treated, and then 35 of them promptly withdraw saying that they do not want to get treated. I do not know what's going on there. So that is one quirk that I found worth talking about. Secondly, around 40 patients on the on the control arm were operated only and did not receive any further adjuvant therapy. Adjuvant therapy not being received could have various reasons, including progressive disease, and we have a whole list of the reasons outlined over here. As for the patients on the experimental arm, which is the patients receiving pembrolizumab, so only 3 patients were not treated. And now a hypothesis would emerge. This was by necessity an open label trial, right? You cannot explain to a patient why you are not operating them if the patient is the patient is not. I mean, you cannot even ethically justify a patient not getting operated if you're not going to give them any neoadjuvant therapy at all. So possibly because of the open label nature of this study, patients on the control arm of this trial, once they found out that they were not going to receive immunotherapy, they elected to withdraw and possibly went on to be treated along whatever oncological center they chose. So that is one hypothesis I personally had. As far as the experimental arm goes, we find that around 30 patients completed the neoadjuvant pembrolizumab, but did not actually move on to go on to surgery. Out of these 30, only half were due to progressive disease, 4 were due to adverse events, 1 lost to follow-up. I think these numbers hold up quite well in clinical practice. So it is fair to expect that between 5 and 10% of patients, if we start them on the neoadjuvant pembrolizumab, may not get operated upon, which of course is one of the fears with this approach, which is why we are having this debate. And moving on for the further consort, we find that around 55 patients did not take any adjuvant therapy. And that, of course, can be a matter of consent and a whole lot of other stuff. So eventually, however, around 88% of patients on both arms underwent surgery. But as can be expected, in the experimental arm, only 58% patients completed all protocol therapy, while 83% patients completed all protocol therapy on the control arm. So this was, of course, because patients were planned for 12 more doses of immunotherapy after surgery, and they could discontinue treatment due to several factors, including adverse effects, including progression and other stuff. So this was the consort statement, and I find I find great importance in going through this consort statement because head and neck cancer, unlike lung cancer, resectable head and neck cancer is kind of, among the bread and butter for our surgeons, for us radiation oncologists, and us oncologists in general. So, this data is worth going into. Coming on, of course, to the Kaplan-Meier's EFS, they have announced it to death. We know that pembrolizumab is a part of the NCCN guidelines already. So for all comers, for CPS more than 1 population and for CPS more than 10, we find that the EFS at 3 years is improved by anything between 11 to 14%. Hazard ratios progressively improving from all comers to CPS more than 1 up to CPS more than 10, statistically significant improvements. So that's that. So yes, EFS is improved at least at the 3-year time point with a median follow-up of 38 months. No questions really there. And when we go down to analysis by subgroups, we find that for CPS more than some interesting points, maybe quirks, maybe interesting points, I do not know. Numbers are small. So females, maybe not so much benefit. Never smokers, maybe not so much benefit. CPS more than 1. We find that patients with hypopharyngeal tumors, a complete left field result, hazard ratio of 2. So patient seems to be doing twice as worse when they are actually given immunotherapy in hypopharynx. A lot of stuff to discuss there. Similar trend when we go for all comers. Essentially, I guess we can summarize it as saying that patients with hypopharyngeal primaries did not benefit as much. Females, patients with age more than 65 and with stage 4 tumors possibly did not benefit as much. But overall, in general, the benefit does seem to hold up. It is the point is that as the keyword operating word here is as much, because in general, we can find that the net of the forest seems to be on the right side, I mean, on the left in this particular case. As far as the treatment discontinuation is concerned, the one point I'd like to point out here is the progressive disease. So around 43 patients did not continue therapy on the pembrolizumab arm because they developed progressive disease. Now, that, of course, is inclusive of patients who are the early progressors, right? So we all have seen those patients who have undergone surgery, have progressed maybe even prior to radiation, maybe progressed on radiotherapy, or maybe even progressed during adjuvant therapy. Now, given that on the control arm, this number is just 7, I am inclined to believe that this 43 is predominantly contributed by those patients who have progressive disease from adjuvant phase. And that, of course, is our experience. These are high-risk patients, and a lot of our patients will experience progression within the first year itself. In fact, that is the bulk of those patients who have progressive disease. So that is, of course, the concern with adjuvant pembrolizumab. As for the patterns of failure, now this is where this is a bit of a, the no-brainer. We know that we are giving systemic therapy. The patients should have lesser distant failure. So in CPS more than 10, in CPS more than 1, and in fact, even on the all-comer population, patients who received pembrolizumab had fewer distant recurrences, that is, fewer metastatic events. So 15 versus 39 for the CPS more than 10, 24 versus 51 for CPS more than 1, which is, of course, all in good. We really like that. Nothing really surprising there. How about the data for the Nivo post-op? Of course, we do not have very comprehensive data sets. It is just an ASCO presentation. We do not have the full manuscript, but what we do know is that the median follow-up is around 30 months at present. The DFS at 3 years is 63 versus 53, so a delta of around 10%, hazard ratio 0.76. For OS, we are immature, but for what it's worth, 74 versus 68% at 3 years. And when we go on to looking at this whole thing by subgroups, we find that there is no real stratification for PDL1. So it seems to be a bit all over the place. But I guess for PDL1 CPS less than 1, there is not so much of a benefit. But then it also seems to suggest that for CPS more than 20, also the benefit is not great. Given that this was not a stratification factor, I am not sure how much we can read into it. At least the numbers involved are fairly significant. So that's nearly 250 patients. So definitely food for thought, but without stratification, difficult to comment upon. For what it's worth, at least the overall forest looks good. As far as the recurrence is concerned, recurrence patterns, what TFS events are happening, this is where we are tossed for a 6. The loco-regional events are what are being reduced dramatically by the addition of nivolumab. 61 for the standard arm, and when we add nivolumab, the number goes down to 39. Whereas when we look at the distant metastasis, it is quite similar, 37 versus 40. So now, opposite to what we see is in 689, patients who are receiving nivolumab actually do not seem to derive any benefit in terms of distant failure. But ulta, we are getting more benefit loco-regionally. How is that happening? Why is that happening? Plenty of theories, plenty of discussions going on. Immune sensitization, tumor milieu not being disturbed preoperatively with pembrolizumab. I have no idea what's going on over here. I doubt many people do, but the data is what it is. Uh, so for the time being, all we know is that yes, nivolumab is reducing locoregional recurrences, by pembrolizumab is removing distant failures. What are the historical results? So we find that the 5-year PFS was initially around 36% with RT, and 5-year PFS was similar for the RTOG, and the combined analysis has also shown us similar numbers. So 32% to 40%. While in these two trials, we find that at least at 3 years, the PFS seems to be hovering around 60 to 65%, which is much higher, and which is what we should expect. I mean, going forward, because it has been 20 years since these old seminal papers were published. I mean, they were seminal back 20 years back. So, I mean, it has been a real long time since we've been able to move the needle. So, definitely good to look at. So, after all of those numbers for nerds like me, I guess, what are the unanswered questions here? And this I have borrowed. It's a very nice looking summary from a review that was published earlier this year. But I summarized it in my from the questions that I have. Does the concurrent part help? I mean, of course, we have a lot of data for the concurrent chemoradiation studies, and in those studies, the concurrent immunotherapy does not seem to be helping. So, in this study, is the concurrent part helping at all? The next question, which is a natural extension, is the neoadjuvant or the adjuvant component helping? Do we even need both components? Can we get away with just one? So same question, do we need induction, concurrent, and maintenance, or just one of the two, one of these three, or in combination? Specifically, what is the efficacy for this approach in PD-L1 non-expressing tumors? We do not know, because Keynote 689 had only 4% of these tumors. And in Nivo post-op, while the number of tumors is around 12 to 15%, we do not really have the full manuscript yet. And what impact does HPV have on all of this? Not sure how relevant that is. This is predominantly for oropharyngeal cancers, which do not typically get operated, but that also remains a question. What am I concluding? What am I concluding after all of those numbers that I went through? So essentially, it is going to be shared decision making. We have to remember that the risk of progression for a patient with resectable oral cavity cancer is simply not acceptable. I mean, at least personally, not to me in the clinic. A patient who has been put on pembrolizumab, develops progressive disease, and becomes unresectable, it is a very, very difficult and unpleasant conversation to have in the OPD. And we do not really know. I mean, we know that all patients do not respond to immunotherapy. We do know that from our work in the clinic. So maybe those patients were never going to benefit from immunotherapy in the first place. And just trying to explain to them based on statistics. So Keynote 689 versus Nivo post-op. Drumroll, no surprises. My answer is Nivo post-op. There are too many unanswered questions with Keynote 689. The risk of progressive disease prior to surgery is simply not acceptable in my own head. I cannot explain it to myself. How am I going to explain it to the patient? What is the future? Well, maybe we add chemotherapy to the ICI. We do have a lot of those studies in NSCLC now. The Checkmate 816 was the neoadjuvant only, 671 was perioperative, IM Power was adjuvant only, and that comes back to the same question that I asked previously, I guess. Does ctDNA have a role here? Maybe that can guide us. Do EGFR inhibitors have a role here? If immunotherapy can help in this setting, why not the EGFR blockade? What role does oral metronomic have? I mean, if it works so well in the palliative setting, maybe even in the neoadjuvant setting, based on some data that for the limited phase 1, phase 2 data that we have from Tata, right? So if the home CT helps there, so why not in the definitive setting for all patients? And lastly, what role can low dose immunotherapy play for these patients? All unanswered questions. I doubt we'll get all of these answered in our lifetime. At least we will see what happens. I guess that's it from me. Thank you.
Thank you, Dr. Animesh. Excellent talk as always, and your in-depth analysis of the trials. So, of course, you yourself has pointed very well what are the pitfalls. So, mostly, if you ask about what I would say, those 45 patients which progressed on Keynote 689, that is very important. You also have to see those patients if they progressed after the initiation of pembrolizumab or not. Their response to pembrolizumab also needs to be checked, because maybe they have progressed to pembrolizumab and then after surgery they have progressed. So a lot of things are still there, but
So I have a
So,
You know, yes,
Ashish.
doctor, please.
Two, three. The first thing, Dr. Animesh, very nice talk. But since I have been using pembrolizumab in NACT, so altogether we have 6 patients, and we have 1 patient of hypopharynx, where the CPS score was 30, and we told to the patient, and we have given. He's an 86-year-old man, but we with given pembrolizumab, excellent response. Now it also come handy in the patients who are geriatric age group. So we have
Absolutely.
I have a subgroup of patients where I've given in PDL1 negative, because then also there was some benefit. I told them, although the percentage is very less, but you don't have a choice when a patient is a diabetic, ejection fraction is 40%. So I think the pembrolizumab, the distant failure was less because see they started pembro in NACT, and here Nivo was started after surgery. So that explains why the pembro was able to control the distant failure more. Second thing,
Go on.
second thing, the PDL1, which you are talking, the PDL1 percentage less. We have been using the PDL1. Of course, that we has come through this thing. We have come through the ACA cervix data. There we are not using PDL1, and we have now this data of CT-RT with pembrolizumab. I have 2 patients where we have, because of the age, we have not given cisplatin to this patient. Even carboplatin they didn't tolerate it. So, but we have a very good response for pembro with radiation in CS cervix 2 patients. In 2 patients, even this patient also the hypopharynx patient, we are going to give radiation with pembrolizumab, no cisplatin, because 86-year-old he won't be able to tolerate. And I don't know how the HPV status is going to help affect the immunotherapy. I don't think they have neither nivolumab or the pembrolizumab, they have taken this subtype into the picture.
True.
So all very valid points, Dr. Satish. In fact, that those are those are the kind of edge cases that make us very concerned. I mean, about applying this strategy on a blanket basis, right? It cannot be a strategy that will work for everyone or not work for everyone.
But I
We
think
have to be flexible. Agreed.
CPS more than 10, I think pembro will have very good response. That's what I have been seeing in my practice. With excellent response.
Absolutely agreed. So, I mean, even in this trial, the response is when the data speaks for itself. The EFS improvement, especially for CPS more than 10, is 13%. And the statistics don't lie. I mean, if I'm sitting in with my patient in the OPD, I can confidently tell them that your result, statistically, at least 10 to 15% more patients are expected to be living without recurrence at 3 years, right? So that those numbers don't lie. The problem is
So
not the longer time
to
horizon. The problem
now,
is sitting in an OPD with a patient who developed hyperprogression on immunotherapy, right? The hyperprogressor, or the patient who developed progression and cannot be operated now, and now and I have to have that
so
that
what percentage of
uncomfortable
patient,
conversation.
what percentage of the patient they hyper progress on this keynote 689 trial?
Right.
Do we
So
have
it doesn't have to. So it
That
doesn't
data, so
necessarily have to
no
be
one will
just
tell you.
hyperprogression. But
The
out of I'm telling you, I'm giving you the exact number, right? So out of the around 350 patients who are out of the 350 patients, around 350 patients who were randomized to this arm, around 30 patients did not get operated. Okay. Now,
Okay.
the out of the that not operated could be due to several reasons. But out of these 30 patients, around 22, 21, 22 odd did not get operated because of either progressive disease or checkpoint inhibitor toxicity. Okay. So that is still so while that number is down to 10% only, so only 10% of our patients will not be operated due to progression. Okay, but even 5 to 10% of our patients in a clinic, I mean, hopefully with time we are all going to get very, very busy. I'm far not as busy as you yet, but possibly I will be sometime in the future.
So
But
to
yeah,
answer your question, Dr. Animesh, what I have done is I've also started neoadjuvant pembrolizumab in few of my patients with the burden of disease which we get in our PD. I'm not comfortable starting with only pembrolizumab. Okay, I add
So
chemotherapy to it
I
for 2 to
think
3 cycles
nobody
and
will
then
start. I think in our practice, nobody starts a single agent pembrolizumab. Like I have started in 2 patients because of the geriatric age group,
yes.
and they initially progress. So you have to add carboplatin.
Okay. Okay, thank you. Wonderful talk, Dr.
And
Animesh.
you have asked me OMCT why. So I think OMCT mein most of the disease are stable. most of them we are not looking for the disease, the size reduction is not there. OMCT के साथ तो मतलब
Dr.
maximum
Satish,
disease.
I'm really sorry for interrupting you for this moment, but I have to tell you, this is such a fascinating discussion. I saw 1.5 hour discussion by some senior medical oncologists on this. I had another half an hour worth of questions after that.
We'll have a separate session for that, Doctor.
नहीं तो
Don't
we
worry.
add like those patient whose CPS is good and they cannot afford pembrolizumab. In all our Ayushman patient, we are adding nivolumab. See, because if you see the
Agreed.
interleukin 6 release because of the pembro or nivo, the quantum of release is same. So probably you are going to get the same response. Only thing
Absolutely.
you don't have data.
The low dose immunotherapy is a phenomenon. अभी ESMO में present हो तो गया. What was the name of the study? The low dose for TNBC.
हाँ, pembrolizumab. So we have
low dose
already
pembro for
added pembro का TNBC में data है ना, low dose का.
So I think we are running out of time.
I want to add one question,
Yes,
Ashish.
yes.
Please go on.
First thing is like whatever Dr. Animesh said, I agree. See, actually, I have one patient whose CPS score was 90. Okay, so in that patient, I've actually started neoadjuvant solo IO therapy, and he's responded really good, you know.
Yeah, it's they respond. Yeah.
See, and I'll tell you another thing. The drawbacks of this study, what we need to quote is they have not classified or there's no subgroup data for HPV positive patients. That's one thing. And post progression data is not yet come. Okay, post progression, what you're going to do.
Absolutely.
So that is the question where we need to answer. If a patient,
For those two things, I'll say one thing. I think we talked about this briefly before. Patient selection has to be paramount. A patient with the young 35-year-old with 2 months ka history with rapidly progressive disease and a T3 N2B primary clinically, that patient is probably not the right patient for the solitary IO, right? But maybe a 65-year-old patient with slowly progressive 2-3 month history and a T3N0 disease, CPS of 90 as you have found. Maybe that is a very good patient for a pembrolizumab, especially after he or she understands the implications of going with such an approach. And the second part of this pie, where you talk about the post-progression therapy. So the post-progression therapy in head and neck cancer, my personal experience, if it has come to post-progression therapy in head and neck cancer, we really do not have much time and forget the quality of life. That's
the thing
quite.
actually,
So,
if you look into it, they mainly wanted to make it more resectable by adding an IO. So the question keynote didn't address is, even though you have taken a selection of borderline resectable, post progression of IO, they have become unresectable or they've gone to a palliative intent. So that question, keynote 689 doesn't answer.
So keynote 689 will that unfortunately by design it will never be answered because
Yeah,
those patients
You
go off
also have to
protocol, right?
understand another important
Those patients will go
point.
off protocol.
Patients with margin positive or extracapsulation will be only 20 to 30% of the total patient. So Nivo post-op you can offer only to 20 to 30% of the total patients.
No, you don't. You do not. We are saying we are talking about high risk cancers. It does not have to be positive margin. Na? ENE is also one of those criteria.
That is 20 to 40%, 20 to 30% total.
So, and they have also allowed more than 4 nodes, right? So that is another thing.
See, I think
And
what I would understand is a selection of good subset of patient is what I would take into consideration. I don't think I would offer to all patients.
Absolutely,
If I feel the patient is upfront resectable, go for surgery, no doubt. Borderline resectable, definitely I look into the CPS score, age of the patient, extension of tumor. If he's going for any hyperprogression, I think I would stop my IO and then go possible for surgery or go for a curative intent. If patient is responding, I think then I would continue. I think that's what we need to understand with this trial.
Absolutely. I think that is a very, very vital point that you just raised. We have to be very, very on the money about following these patients who are on neoadjuvant IO. Maybe even weekly clinical follow-ups. Jahan you have a doubt that the disease is progressing,
the next topic
do not take the
because I think
chance.
it's
so
too
we
late.
have
We
this.
have a panel
We have this.
discussion. Dr. Satish, we have a panel discussion, another talk to go. I think we should wrap this up and we should move to the next topic and we can have this discussion later. Okay?
Thank you, but it was a good discussion.
Thank you. Thank you, everyone.
Thank
Dr.
you.
Animesh.
Thank you. Thank you.
So next talk will be by me only. So just let me share my slides. Are the slides visible?
Yes, they are visible. You can make it big.
Okay. So basically, so I'll be presenting a couple of cases on ABCP and along with the Ipsos data. So the first case, It's a 42-year-old male presented with cough, chest pain. HRCT showed right lower lobe consolidation with hydropneumothorax. Just a minute. Right. The PET scan was done, which again showed right lower lobe mass with pleural diffusion and with pleural effusion. This is the PET scan report of the patient. CT guided biopsy was done, which showed well differentiated adenocarcinoma. The patient had done EGFR AL cross out from outside. It shows EGFR mutation by sequencing, and it was negative. It shows no amplification. So patient was started on pemetrexed and carboplatin for 6 cycles. So then after that, this is the PET scan of the report before and after chemotherapy. On the right side, we have the post-chemotherapy. On the left side is the pre-chemotherapy. You can see the medial component of the disease responding well. But on the lateral aspect, there was a new disease lesion. So basically, it was a mixed response. So the question is, how often do you see mixed response? How do you usually proceed in such cases? And what will be your next line of treatment? So mixed response is not very common. We see around 2 to 3 patients out of 10. And basically, how to proceed, clinical response is very important in those patients. In this patient, again, just because the clinical burden was high, the patient was started on taxane and pembrolizumab. And after 2 cycles of pembrolizumab and taxane, this is the patient's condition. This was the patient's condition. You can see the frank clinical progression, the tumor coming out of the chest wall. And the patient was having a PS of 2 to 3. So the question was, what next? We already ran out of 2 lines of treatment, exhausted immunotherapy. Should we go for biopsy, NGS, any role of liquid biopsy? Should we assess co-mutations, or is there something else we're missing on? So again, repeat biopsy from the progressive lesion was done, which again showed adenocarcinoma. And in the meantime, I started ABCP to this patient. And after 1 cycle of ABCP, this was the response of the patient. There was clinical response, and another cycle of ABCP was given, which was again followed by more clinical response. And in the meantime, what I got was this NGS report, which showed EGFR positive with a VAF of 16.6%, Del 19. So after this NGBS, the patient was switched to 4 cycles of osimertinib plus pemetrexed and carboplatin. That is FLORA-2. The reason why I added pemetrexed and carboplatin, because the patient had mixed response with pemetrexed and carboplatin. And this is the patient's condition after 4 cycles of pemetrexed and carboplatin. And now it's been more than a year now, and the patient is doing very well on osimertinib and pemetrexed. So we'll talk about now IMpower 150 trial. It's a phase 3 study which took chemo-naive non-squamous patients randomized into 3 arms. ACP followed by atezolizumab. The second arm was ABCP followed by AB. Third was BCP followed by bevacizumab maintenance. The primary endpoint was PFS and OS. The baseline characteristics were well balanced, and around 10% of the patients they had EGFR positive, which was usually excluded from other IO trials. So if you talk about the PFS benefit of this, specifically EGFR positive, EGFR ALK positive subset, you can see the median PFS increasing from 6 to 9.7 months. If you talk about the OS, that OS also increased from 18 to 29 months. But if you compare arm A versus arm C, that is ACP versus BCP, then there is no difference between both arms. So it was the addition of ABCP that was doing something to these EGFR positive patients. Dr. Satish, I think you're not mute. So if you talk about the overall response rate, that also was more with ABCP 71% versus 42%. ABCP also had 6% complete response, which was not seen in the placebo arm. And the median depth of response was 11 months versus 4.7 months. So we know what are the different to treat co-mutations in CL lung. We know KRAS, KEAP1, STK11, LKB1, and the data is there which says that these mutations, they are associated with increased hazard events. For PFS and OS, it was more than 2. So what about these different to treat co-mutations in IMpower 150? You can see KRAS positive patients were present in around 25%, STK11 11-15%, KEAP1 15%, and T53 around 42% of the patients. So what about the efficacy of ABCP in this difficult to treat co-mutate patients? So on the left side is the ITT population. In the middle one, we have the KRAS mutated subtype. And on the extreme right, we have wild type. You can see the KRAS mutated subset clearly, that is the blue curve, clearly getting benefit with ABCP as compared to rest of the 2 arms. This benefit was not seen in KRAS wild arm. Again, if you talk about STK11 and KEAP1 mutated patient, again in those subsets, you can see there was benefits of ABCP over ACP or BCP alone. So, and if you correlate these co-mutations with PD-L1 expression, you'll find that those patients with mutations, they are associated with low PD-L1 expressions. And the ideal treatment for these patients is IO doublet with chemotherapy, which was discussed very well by Vamsi sir. Checkmate 9LA also showed that this different to treat co-mutation KRAS TP53 positive, they fare well with Checkmate 9LA arm. And we also have evidence of combination of anti-VEGF 2 EGFR positive patients 025567 with addition of bevacizumab to erlotinib increase the median PFS from 9.7 months to 16 months. So this again is a very good paper in which different IO trials was taken, and among all these different IO trials, this difficult to treat co-mutations, STK11 and KEAP1 was taken, and their outcome was compared. You can see the best outcome of this STK11 patient, both in terms of PFS or OFS, was that with IO doublet, either durvalumab with chemotherapy or nivo-ipi with chemotherapy. Another regimen which is doing well in these subsets is ABCP. Similar finding you can find in KEAP1 positive patient. Also, you can see IO doublet doing well with chemotherapy and ABCP also doing fairly well. So to answer this question, we have a phase 3 trial ongoing. That is Triton trial, tremelimumab plus durvalumab versus pembrolizumab in combination with chemotherapy, non-squamous metastatic non-small cell carcinoma with STK11 and or KEAP1 and or KRAS positive patients. Now coming to my second case, this was a 41-year-old female presented again with cough. PET scan was done. PET scan showed left upper lobe mass with mediastinal nodes and multiple bony metastasis. The PET scan also showed a low-grade metabolism in upper pole of right renal cortex. This was the PET scan picture of the patient. Biopsy was done from this patient, from the lung mass, which said carcinoma with clear cell features. And we had a discussion with the pathologist also. The pathologist told me to go and look for any renal mass or not, because this biopsy specimen was showing clear cell features. Then in the PET scan also we had a renal mass. So again, ISC was done, which showed CK11 positive, TT11 positive, and HepPAR positive, and it was negative for PAX8 and CD10. So RCC was ruled out. But again, another doubt came just because HepPAR was positive. Now the pathology was insisting that it can be a case of hepatocellular carcinoma. But on PET scan, there was no hepatic mass. So again, AFP also was sent in this patient. AFP was normal. So the final diagnosis after clinical radiohistopathological diagnosis was it was a hepatoid variant of adenocarcinoma lungs, HAL. The NGS of the patient was sent, which again said KRAS positive. So what the experience with these type of cases like intestinal variant of CA lung, again hepatoid variant of CA lung, these are very aggressive types and they are very rare. So what is HAL? Hepatoid is a rare extrahepatic tumor with morphological characteristics like hepatocellular carcinoma. Majority of them have origin in ovary, lungs, gallbladder, pancreas, and uterus. About 5% they have primary sites in lung and well. So it's very important to do ISC because morphologically they mimic hepatocellular carcinoma. ISC markers like AFP, TTF1, HepPAR, CK, they all are very important to differentiate SCC from CA lung. The largest case series was by Johnson et al., in which 42 cases of HAL were present. The median age was 58.5 years, 85% were male, 62% had smoking of history, with a median amount of 40 pack years. The most common site was right upper lobe, and second was left upper lobe, which was the case in our case. 53% of the patient has normal AFP, and majority 76% they present in advanced stage, and median overall survival is dismal of around 14 months. So this is the case series which they're having. You see the overall outcome is very few, either single or double digit. The only patient which fared very well, you can see the fourth last patient showing median outcome of around 51 means surgery was a part of that treatment. So these patients, maybe they had early stage and surgery was a part of this. Another patient doing very well was 53 months in which bevacizumab and pemetrexed was given. So again, IO plus bevacizumab combination was given. The largest data which we are having from India is from Rajiv Gandhi Cancer Hospital. It is of 6 patients. You can see the first patient had stage 3B. The median outcome was 23 months. All rest 5 patients had stage 4. The median outcome you can see 2 months, 8 months, 2 weeks, loss to follow-up, and 2 months. So what should be the preferred regimen in this patient? What I did was, again, I started ABCP with the content that maybe atezolizumab, which works in hepatocellular carcinoma, also can work in this patient because we treat the biology as well. So this is post 6 cycles of ABCB, there was significant decrease in the response. There was significant decrease in the tumor burden. And the patient is still on AB maintenance for the past, say, around 6 to 7 months and doing pretty well now. So now coming to the Ipsos data, we all know that in our country, most of the lung cancer patients, they have advanced stage. Their age is also high, and they have PS of 2 to 3, even 4 also. They are not eligible for any trial. So we have a trial of unfit those populations. In Ipsos trial, unfit lung cancer patients, those with performance status 2 to 3 or performance status 0 to 1 with age more than 70 and who were platinum ineligible were taken. They were randomized 2:1 into atezolizumab versus chemotherapy enrollment gemcitabine alone. The median outcome is COS increased from 9.2 to 10.3 months. The 2-year OS was double, 12 versus 24%. The objective response rate was also double, 8 to 17%. And if you talk about the side effect, it was less with atezolizumab. Grade 3, 4 adverse events were seen in 16% versus 33% in chemotherapy. So you can see the curve at 2 years, 24 versus 12%. So atezolizumab with less side effect is doing fairly well in these patients for ECO performance 2 to 3 or even 1 or 0 who are platinum ineligible age more than 70. If you see the forest plot, almost all the groups got benefited except those patients with 80 or more. The patient, they were around 97 patients, but the benefit you can see was less. Rest, all the subgroups got benefited of these patients. If you talk about the toxicity, that also was less with atezolizumab as compared to chemotherapy. So it's a fairly good regimen. So that's it from my side. If you have any talk, I'll be happy to answer. Thank you.
Thank you, Dr. Ashish.
Okay, if there's no question, over to you, team.
So next up, we have a very interesting segment that is a panel discussion. I would like to invite the moderator, Dr. Duncan Khanekar. He's a consultant medical oncologist at Assam Cancer Care Foundation. Welcome, sir.
Good evening, sir. Welcome.
Webinar is really infectious. So I must thank Ashish Bhai once again for the kind invitation. And on a lighter tone, I mean, I see a lot of familiar faces here. So it's a mini reunion of GCRians. So just give me a minute to share my slides. So my slides are visible, right?
Yes, sir.
Yeah, without further delay, let us get into the panel discussion. So we have 4 panelists today. So probably I will call upon Dr. Gautam from Ahmedabad.
Hi, sir. I'm here, sir. Yeah.
Yeah, hi.
Sir, good evening. Yeah.
Yeah, good evening. Dr. Shreya.
Good evening.
Yeah, good evening, Shreya. How are you?
Yeah, I am good. After a long time.
Yeah, since our BBC days. Dr. Debajyoti.
Good evening, sir.
Yeah, good evening. And Dr. Debanti.
Good evening. I am here.
Yeah, hi.
Hi.
Very good evening to all my distinguished panelists. So definitely we will be discussing primarily on HER2-positive breast cancer, especially in the curative setting. And just to give a brief overview. So maybe if we go back to to the 1990s, I mean, HER2 positive breast cancer was considered far more aggressive and with worse survival compared to even TNBC. So then came trastuzumab, which actually changed the entire scenario, and we see a lot of improvement in the years as new and newer molecules have come up. So starting with a single HER2 blockade drug, now we are considering dual HER2 blockade, and then came in platinum agents, which seem to provide a very good pathological complete response, which is a newer form of surrogate marker for almost all clinical trials nowadays in the curative setting, primarily in breast cancer. And probably then came in TDM1, and now probably a much better molecule with the name of Enhertu. So things are changing quite rapidly in HER2 positive breast cancer, and definitely for the good of our patients. But this has made our decision making more and more difficult, specifically because it's almost like a menu in a very good restaurant. You are not sure what to choose from, and which will be the best for a particular evening. So just to sort out and to have a very good idea, after we conclude this panel discussion, probably we will leave this webinar with an idea of how to manage a HER2 positive breast cancer, specifically in our clinical practice. So I must first thank Roche for the slides that they presented, that gifted to me. So this will just be a launch pad of our discussion. So this is just a hypothetical case of a 40-year-old female, and she has a relevant medical history of hypertension with diabetes mellitus and no history of serious cardiac comorbidities. So probably that will be more important for us, and with a very strong family history of breast cancer. So that is a very unique thing, specifically because as we will be discussing primarily HER2 positive breast cancer. So on physical examination, she was found to have a left breast mass, 6 centimeter, involving the skin with axillary node, probably matted nodes. And biopsy was done, ITC grade 3, hormone negative, with HER2 3+ by IHC, with no evidence of distant match. So the disease status clinically is T4B N2M0, that comes up to be stage 3. So stage 3, CA breast, HER2 3+, hormone receptor negative, IDC grade 3. So this is in short about our case with a strong family history of breast CA. So definitely we will be doing a good metastatic workup considering the burden of nodal disease, and definitely there were no distant metastases. So the PET-CT also confirmed the fact that there were no metastases, highlighting only the breast and the axillary nodes. So I'll probably start with Dr. Gautam, and I will just ignore the questions that are in place in the slide. I just want to know, how many HER2 positive breast cancer patients do you usually find who have a strong family history of breast cancer in your clinical practice?
So family history is not as common as say triple negative or hormone positive, but then it is there. It is not like it is very rare, but proportionately it will be a lower percentage. It is not unheard of. It is proportionately lower compared to triple negatives, and definitely triple negative will be more common. I mean, we see more commonly triple negative with a significantly strong family history.
Definitely, definitely. I mean, surprisingly, HER2 positive presentation is not too common with hereditary breast cancer patients, and it
Yes.
comes up to even, I mean, probably less than 10% of all hereditary
Yes.
breast cancer, particularly
Yes.
with BRCA1 and 2.
Yes.
So
Isolated HER2
yeah,
positive.
yeah.
Yes.
but definitely, probably we will go for genetic counseling even in this case. So
Definitely.
that will be not a point of discussion today. So I will go ahead with Dr. Shreya, and I believe we are in the phase where we discuss about PCR, about the role of neoadjuvant chemotherapy, neoadjuvant systemic therapy in breast cancer. But we all know that if you go by the meta-analysis that we have till now, it hasn't proved that neoadjuvant chemotherapy is superior to upfront surgery. We all know that it is non-inferior. So, Dr. Shreya, what is your opinion like? So if a case similar to our case comes to you in clinical practice, what talk do you have with a patient? Like, suppose the patient wants to have upfront surgery. So, what will you tell the patient?
See, for this case, it is locally advanced, HER2 positive, and young patient with a positive family history and hormone negative with a nodal burden. So these are the risk factor. I have to make them understand that if upfront surgery they just prefer, that is maybe not non-inferior, but in long run, it increases the chance of recurrence, and the patient might not understand the term pathological complete response and all, but we have to make them understand in a simple language that if we can reduce your tumor before surgery, and that will be helpful for the surgeon for your long term outcome. So that will be our point of discussion, mainly considering the risk factor and the benefit of the neoadjuvant therapy before surgery. And ultimately the patient will actually the patient and patient relatives are apprehensive because they think that if I go for surgery upfront, the treatment will end that way. So but I have to make them understand that she will be requiring chemotherapy and 1 year adjuvant trastuzumab in any way. So better go ahead with chemotherapy first and then go for rest of the treatment.
Yeah, very well said, Dr. Shreya. Yeah, definitely in our clinical practice, we have often faced this issue. Like the patient comes to us with the hope that they will have a surgery first. It's sometimes very difficult to make them understand. But yes, as Dr. Shreya has stated, probably we, specifically in this case, which has a very high risk of distant recurrence in the long term. So probably we must counsel them that maybe in light of much better molecules that we have at hand, probably she will be better off if we start with neoadjuvant therapy, because that will also downstage the disease, maybe resulting in much less morbid surgery, and also, or should I say, conservative surgery, and probably this will also provide us that whether she falls into the high risk strata, where we have to be more stringent with our adjuvant therapy. So these are the facets that probably a new adjuvant therapy assists us with in our long-term decision making. So definitely there are certain aspects like lymph node positivity, Ki67, a large tumor size. These actually render a particular tumor to have a very high risk of distant recurrence as well. So definitely, I will go ahead with Dr. Debajyoti and ask a very pertinent question like what is the specific role of a multidisciplinary tumor board, specifically in a case like our own patient here. So what role does the multidisciplinary tumor board has?
Yes, sir. Especially of all type of breast cancer, we should be discussed in multidisciplinary board, including medical oncologist, surgical oncologist, and radiation oncologist. Although this type of case, like in our case, T4N2 disease, straightforward as per the most of the guideline, we can directly go to the neoadjuvant part first, then for the surgery. But however, still we should be discussed in MDD, and especially for those cases. Those are borderline cases like stage 1 or stage 2A or 2B with the HER2 positive or TNBC cases. In that cases, the TNBC ability discussion really helps.
Definitely, definitely. Very well said. I mean, we must always stress upon the importance of multidisciplinary tumor board, not only in this case, in every case,
In
because
every case, sir. Yes.
the care should be holistic. And
Yes.
for example, I mean, the surgeon might be more interested in clipping of the nodal lesion, or maybe he might be more concerned with the surgery that he will be able to do after the neoadjuvant response. So these facets matter a lot, specifically after we do our job and hand over the case to the surgeons and then to the radiation oncologist. Definitely, reconstructive surgery is also an important part that we need to discuss. So, I mean, multidisciplinary tumor board is essential to decide upon what therapy is the best for a particular patient, and this will actually provide an individualized therapy for each and every patient. So, I mean, definitely post neoadjuvant chemotherapy or neoadjuvant systemic therapy, there is always the question of residual cancer burden. And this is actually understandable that more the residual disease, the poorer is the disease-free survival. And as you can see here, those who have almost pathological complete response, they have a 92% 5-year DFS or relapse-free survival, and just half, it comes down to almost half if the patient has an extensive residual disease. So the neoadjuvant systemic therapy plays a very big role in what the patient will have post treatment. So the patient's quality of life as well as the recurrence free interval matters a lot with the neoadjuvant therapy that we select. So this is the NCCN guideline in short, and it states the algorithm of how to select on how to stratify patients based on the tumor size, the nodal involvement. So for our case, it's actually a stage 3 disease. So probably we need to be more intensive in our therapy. Maybe go ahead with the dual HER2 blockade, definitely yes. And the question is about anthracycline free, or we are, or whether we are more comfortable with the anthracycline regimen. So I'll be asking Dr. Demanti that what I mean, trials aside, so what are you more comfortable with? Whether you are comfortable with an anthracycline free regimen and or the conventional regimen of AC Taxol plus dual HER2 blockade.
Sir, in this scenario, I will be comfortable more with anthracycline-free regimen with the dual HER2 block with pertuzumab and trastuzumab along with taxane and carboplatin.
Okay. Definitely yes. But the issue in common practice is that our patients are not too affording for pertuzumab. And yes, I mean, we are stuck with on the utilization of only Herceptin. That happens quite often, specifically in my clinical practice. So suppose the patient is not affording pertuzumab. Definitely new biosimilars have come up now. But
Yes.
suppose the patient is not affording pertuzumab, then what is your which will you prefer? The conventional regimen or the
Actually, I am using anthracycline-free regimen even
oh,
without pertuzumab.
okay. So
But can be used anthracycline, 4 cycle of anthracycline followed by taxane and Herceptin. It can be used.
okay. So definitely, if we go by the results of the trials, particularly the BCRG trial, and that had stamped the authority of TCH regimen to be much better, specifically in terms of DFS benefit. in comparison to AC followed by Taxol plus Herceptin. So if we go by the trial, probably TCH is much better regimen, specifically with less cardiotoxicity. But once we add pertuzumab, the scenario changes a lot. Once we add pertuzumab and we have a dual HER2 blockade, right now we are in that mode where we want to reduce the systemic chemotherapy more and more and move towards more and more targeted therapy. So with time now, we are now considering even a carboplatin-free regimen. So things are changing fast, and with newer and newer trials now, we are more considering a carboplatin-free regimen if we can afford a dual HER2 blockade. So yes, I agree with the panelist that probably TCH plus P or without P, probably TCH is a much better regimen. Although trial-wise toxicities might be more with TCH, particularly the hematological toxicities, but probably maybe for convenience purposes, we are more comfortable with TCH. So as a neoadjuvant, as the NCCN guidelines state, that neoadjuvant therapy is particularly preferred, specifically in the inoperable breast cancer cases, inflammatory bulky, and also in operable breast cancer cases, specifically with high tumor volume, and where we understand that the breast volume ratio and BCS is desired. Node positive disease definitely portends to a very poor survival as well as a very poor DFS benefit. So definitely we need to be more aggressive with the patients who have a node positive disease, and this is echoed by the other guidelines as well, AGO guidelines, ESMO guidelines, same Galen guidelines, that the higher the burden of the disease, whether it be the T size or even the N size, particularly the N size, probably we must move into the neoadjuvant therapy. And probably the best modality of neoadjuvant therapy is dual HER2 blockade. And whether we go ahead with trastuzumab carbo or even move out carbo and just use the weekly taxane regimen, whatever it is, dual HER2 blockade will provide the best PCR benefit. So we have already discussed this, that definitely we will be going ahead with the neoadjuvant therapy. And so a new thing has come up now that definitely I will just keep these slides, because we all know that the PCR rates are better definitely with the dual HER2 blockade, and specifically more with hormone negative and probably lesser with hormone positive. So so new thing has come up, specifically as these slides are provided by Roche. So definitely we have to discuss a very important molecule that they have come up with, FESGO, which is a subcutaneous administration of the dual HER2, trastuzumab and pertuzumab, combined in a single injection. So probably this is a very remarkable innovation, that they've converted into the subcutaneous and they've combined two monoclonal antibodies into one drug. So definitely this has resulted in a shortening of the infusion time, a more convenience to our patients alike, as well as the daycare staff. The preparation time is also very short. Just we need to comfort the patient, and it just takes hardly a minute or two. Definitely, we don't need indwelling venous access, and this results in lesser burdensome for everyone. And as I've already stated, that it contains both pertuzumab and trastuzumab. Pertuzumab in the loading dose is almost 1200 mg. Trastuzumab is 600 mg fixed dose, and with a pinch of recombinant human hyaluronidase, which allows actually administration of higher drug volumes. And so this is a ready to use fixed dose formulation and that we can administer subcutaneous. So I'll ask each of the panelists that what is their experience with FESGO, and oh, do they have anything to add regarding the utilization of FESGO in the new achievement setting? So I'll start with Dr. Gautam, and yeah.
Yes, sir. I agree with what you said. The convenience and all is definitely there. The response rates have also been comparable to. So I've never used the original Perjeta. So compared to the biosimilar we have, I mean, like what we see is PCR rates of about 50-55%. Maybe I've never seen 67-70. I mean, I don't have data to back up, but then from clinical experience, I don't see a very significant difference between the drugs that I've been using. And yeah, patient convenience is definitely there. The patient is, if there is a reimbursement or if the patient comes under a scheme, it is convenient to the patient. No vascular access, whatever you said, I definitely agree with all that you said, sir.
Yeah, thank you. Thank you, Dr. Gautam. And I'll move ahead to Dr. Shreya. And can you share your experience about FESGO and its use in the new achievement setting?
Yes, and definitely, as you have discussed, the all the points are very relevant in a high volume center, because obviously, if we see from the patient point of view, there will be lesser duration of hospital admission, and the IV access are difficult, and the patient are not that much comfortable with 3-4 bottles and all. So that is acceptable for the patient, and for the logistics also, the manpower and the hospital bed utilization, all goes in favor of us also. But the thing is, only if there is no financial constraint, obviously FESGO is a definitely is a very good alternative to injectable dual HER2 blockade. And anyway, the patient has to come for the 6 cycles of doxycarbo injection, and they will take it IV and the dual HER2 subcutaneous, and it is an excellent options, because in the long run, in the adjuvant setting also, they have to get that dual HER2 agent or single, or if they cannot afford, at least trastuzumab. So we can make them as less as we can just access for the IV access. So that is preferable in my opinion.
Yeah, definitely right. Dr. Debajyoti, do you have anything to add?
No, sir. Same thing. Convenience is very good with the subcutaneous variant. I have used in some patients, and efficacy-wise, IV and subcut are both similar. Only is the convenience. If the financial toxicity is not an issue, then obviously a subcut variant is preferred.
Yeah. Dr. Debanti?
Yes, sir. I also agree with other panelists. And one thing I want to say that in trastuzumab, pertuzumab dual or trastuzumab alone, adjuvant therapy, the main concern is venous access. And sometimes due to poor peripheral venous access, we have to put any central venous access in form of chemoport, PICC port, or PICC line. But issue is port line infection, thrombus. These are issues for the patient. And along with other advantages, then FESCO is only 5 minutes injection. And as I shared my personal experience, actually I never used FESCO in new adjuvant setting. But if the pathological there is PCR, then actually I used in sometime in adjuvant setting. After giving IV Patutrastu in the neoadjuvant setting with the chemotherapy, and after surgery, if there is PCR, we have to continue the dual HER2 therapy. Then I used FESGO, and the efficacy and toxicity both were same as per the trial, HANA trial and other trials. So evidence is there, and there is no extra toxicity. So why not to use it?
Definitely. Why? I totally agree with you that we must always welcome newer technologies, and definitely we don't have very strong comparative trials with a significant number of patients comparing subcutaneous versus IV. But definitely yes, whatever data we have, definitely it provides the same benefit or similar benefit compared to IV. Definitely, there is convenience of time. It is time saving. Definitely, it also adds up to financial burden to our patients. But this is what is important in oncology, that we need to individualize our treatment based on the patient's wish and desire, their economic value that they can impart to their own treatment, and what we can assist them with. So with time, definitely we will understand, and we are actually we are in the process of personalized medicine, right from what drug we need to administer to the patient to how to administer the same drug to the particular patient. So with time, maybe subcutaneous administration of these immunotherapy drugs will come more and more as because these drugs, as such, with lesser and lesser toxicities, particularly the conventional toxicities that we see with our chemotherapies, these are far, far lower in comparison to our conventional treatment. And this has provided a very good quality of life to our patients. So, as we have already discussed, definitely we have completed the process of neoadjuvant therapy. So this patient had received 6 cycles of docetaxel carboplatin with Phesgo, and I would like to ask all my panelists alike that uh, that do you do a response adapted therapy? For example, suppose the patient states that the tumor size seems to be increasing clinically for them. So do you do an interim assessment of the disease for those patients, or do you do an interim assessment of all patients, like an interim assessment like a MRI or probably even a PET CT after 3 cycles to assess whether you are on the right track? So maybe any of the panelists can take up the question that are you comfortable with an interim assessment after 3 cycles?
So I don't usually do, sir, until and unless the patient complains there is a clinical increase in size, and on clinical examination also there is an increase, then only I will plan for an interim imaging to assess the response. If the patient is comfortable, if there is no complaint of progression clinically, I am more than happy to complete all the plan cycles and then do the responses.
Definitely. Any other panelists might
Yeah,
be?
I also agree because the patient and breast cancer in a neoadjuvant setting is a excellent tool for clinical assessment. Patient will say herself that the tumor is shrinking. So we will evaluate clinically in every cycle, but for in real ground, I do not practice doing any imaging for interim analysis. If the patient is saying, or I feel that the tumor is not reducing in size and the clinical response is not good, then we can go for clinical apart from the clinical examination for the imaging with a PET CT or MRI, or else we should complete the plan proposed neoadjuvant cycle, either 6 or 8.
Okay. Yeah.
My point
Yes.
is during neoadjuvant therapy, I like to assess the patient clinically before every cycle. And if there is any sign of increase of local progression or any symptoms of distal mets, so or there is no shrinking of the disease, so then I can go for interim assessment by PET CT or other imaging. Otherwise, I would like to complete all proposed cycles of neoadjuvant chemotherapy. Then, then response assessment by PET CT or other imaging.
Okay. So yes, definitely, I totally agree with all my panelists. I do the same. I definitely complete all the 6 cycles, but something new is coming up, specifically just the similar formula that we use in DLBCL. Now people are even considering a response adapted therapy, doing an probably an interim MRI, just to assess the logarithmic response to the initial chemo HER2 blockade. And if the response is very significant, they're even considering removing the chemotherapy and just going ahead with the dual HER2 blockade. So certain things are coming up, yes, but definitely in our clinical practice, maybe completed at 6 cycles, because we have good data with respect to the PCR with the 6 cycles. And maybe some people even have considered 9 cycles, 6 to 9 cycles of TCH at times. But yes, probably completing the 6 cycles will provide the maximal PCR rate if it is achievable, or at least the maximum reduction of the tumor burden. So in this case, post NSCT of TCHP 6 cycles, the patient had excellent clinical response with clinical resolution of the breast mass and lymph nodes, as you can see in the PET-CT. And definitely PCR is what we aim for with any neoadjuvant therapy, not only in HER2 positive, even in TNBC or hormone positive. And what is the experience like? I'm asking all the panelists alike that what is the percentage of PCR that you usually achieve with the neoadjuvant therapy, specifically in HER2 positive?
Around 50%, like I said, sir. I mean, like 50 to maybe 50, 55, like that.
Yeah.
Yes, the same thing, sir. Around 50%.
Okay. Yeah.
Around 50 to 60%.
50 to 60%. So, Dr. Shreya?
So same thing, around
Yeah,
50%.
yeah,
If we
yeah,
use the dual blockade, then it may be up to 60%. But
yeah.
in common practice, we just use trastuzumab as a single agent. So around 50, maximum 55%, not more than
Yeah,
that.
definitely. So our real world clinical practice also is almost similar to what the clinical trial had stated, that a PCR rate of 50% is almost achievable, even with single HER2 blockade at times. But definitely dual HER2 blockade will actually add up 10 to 15% more PCR rates. So things like HER2-DX has come up, almost like Oncotype DX that we use with hormone positive breast cancer patients. So definitely we are in need of good biomarkers to predict beforehand whether PCR is achievable with the chemo and dual HER2 blockade that we are planning for the patient. So these are actually future prospects, and probably HER2-DX has not come up in a big way right now, but definitely in the near future, we'll be utilizing these variables, these genomic imprints, to actually predict the response of the patients to dual HER2 blockade. So I'll just skip the slides for want of time. And so the patient had a left MRM in December 2024. And so the patient had actually residual disease, YPT2N0. And hormone status as well as the HER2 positivity was again reassessed. So do you reassess the hormone status as well as the HER2 positivity again in the post surgical specimen? Do you do that routinely in your clinical practice?
No, I don't do
No,
that
sir.
because there is enough data to say that even if the surgical pathology has become HER2 negative, there is enough data to say that you still need to treat the patient with anti-HER2 therapy. So, I mean, just for even for prognosis also, it doesn't make that big a difference. So I don't routinely check that. It opens more boxes. I mean, it doesn't give me any solutions to any problem. So I don't.
Yeah, I totally agree with you. What about the other panelists? Like,
Yes, I agree with Dr. Sani.
Yeah.
Yes, definitely. Usually, we do not do the repeat ISC on surgical specimen. So, once a HER2 positive, always a HER2 positive. That is the notion for treating HER2 positive tumor. So, definitely, they will require the total adjuvant therapy of HER2 blockade.
Yeah. Yeah, definitely. I totally agree that this actually adds to the confusion and doesn't give us additional information to support our treatment further. And as evidence goes, probably the preservation of the post-operative tissue in either most commonly in formalin actually hinders the proper IHC assessment in immunohistochemistry assessment, and specifically with HER2 positivity, also even with ER and PR assessment. So maybe I don't routinely do it, and I'll go by the primary hormone status as well as the HER2 positivity that I had with the primary biopsy specimen. Yes. So definitely the patient, unfortunately, the patient didn't achieve pathological complete response. So what is the next plan? Maybe I'll go ahead with Dr. Debajoti. So what is the next plan like in the adjuvant therapy?
Yes, sir. Since the patient did not achieve any pathological clearance, so I'll go ahead with sir TDM1 as per the Catherine data for 14 cycles.
Yeah, definitely. So I believe all my panelists will agree with the same suggestion that maybe we'll have to switch over to a much intensive systemic therapy in the form of an ADC, TDM1. And definitely this has resulted in about 50% reduction in the disease-free status. I mean to say 50% improvement in the disease-free status, and probably the only hindrance with the utilization of TDM1 probably is the finance. Although we understand that we have a biosimilar that is far less pricey in comparison to the generic one, but yes, sometimes we are stuck with the utilization of just hormonal of only trastuzumab plus minus pertuzumab in a few cases. But the main rule is if the patient has not achieved the PCR with the dual HER2 blockade, probably we have to go ahead with TDM1 3-weekly for at least 14 cycles. And probably we'll have also a discussion about radiotherapy, adjuvant radiotherapy in this case. So maybe in near future, as we all understand, even the trastuzumab deruxtecan has been assessed in non-PCR patients, and there is a good trial which is comparing Enhertu, trastuzumab deruxtecan versus TDM1, and this might change the scenario in years to come. And just similarly, trastuzumab deruxtecan might come in the neoadjuvant setting as well. So more and more things are coming up, and it has become more interesting of how we manage our patients of HER2 positive breast cancer patients in the curative setting. But right now, probably all my panelists will agree that dual HER2 blockade and with docetaxel plus carboplatin maybe in the more advanced
यार
disease
एक सेकंड
stage
पंखा बंद करना
3
उसके बाद आरिस की तो
stage 3 patients,
एक
maybe
मिनट
in
रुक रहना
stage 2, maybe just weekly paclitaxel with dual HER2 blockade might even work well. So in the adjuvant, if the patient has achieved PCR, if the patient has achieved PCR
sir,
after the,
excuse me,
yeah,
sir.
yeah.
Sir, sorry to disturb you. In interest of time, I would request you to kindly conclude in next
Yeah,
two,
yeah.
3 minutes.
Okay. All right. So
Okay, sir.
this will be just my final statement that if the patient has achieved PCR, probably we are more comfortable continuing with at least Herceptin plus minus pertuzumab. And if the patient has not achieved PCR, maybe TDM1. So definitely NCCN has also stated the same thing, that residual invasive disease we might be more intensive and might even add up neratinib if the patient is affording as well. So with this, I thank all my panelists for the discussion as well as sharing their views regarding the management of HER2 positive breast CA, specifically in the neoadjuvant and the adjuvant setting. And I thank once again the organizers for providing me the opportunity. Thank you.
Thank you, sir. Thank you
Thank
very
you, sir,
much.
for the excellent moderation and the panels as well. So Dr. Animes basically wants to know how to integrate Enhertu here, either destiny based 11 or 9. So your or the panelists comment on that.
Not sure. I am not sure which way to go about right now.
Hello, Duncan sir.
Yeah, hi. So if you want my view, definitely this will be a game-changing trial, the Destiny West 11-1-1, and maybe trastuzumab deruxtecan will come in the neoadjuvant setting. As the trial goes, 4 cycles followed by our conventional chemotherapy and the HER2 blockade. But definitely we have to wait for the final results as well. We shouldn't be pushing it too hard. But definitely HER2 will change the entire spectrum of how we treat HER2 positive breast cancer. It has already changed how we treat in the metastatic setting. So in the adjuvant setting, I am quite sure it will be the drug of choice if the patient has not achieved PCR. In the neoadjuvant setting, maybe a few cycles of NR2 followed by a reassessment to assess whether we need further more systemic therapy.
Thank you, sir. So
Lovely summary.
Perfect. So advancing. So once again, I would like to thank everyone for joining in here, and also my team without whom this would not have been possible. And special thanks to the sponsor Ross, AstraZeneca, Novartis, OneCell, and Reddy's. So over to you, team.
Okay, thank you. Thank you, everyone, for joining today's webinar. And good night, everyone. Thanks to my team, Jalak and Avni, and the support team. Thanks, everyone, for joining. Meet you tomorrow at the same time.
Thank you, sir.
Good
Thank
night,
you.
everyone.
Good night.
Thank you. Thank you, Ashish sir.
Thank you. Thank you all.